Most students approach pediatrics backwards. They memorize diseases when they should be learning patterns. I used to struggle with why the same disease looked completely different across questions. Then I unlocked the secret. Peds isn't about learning pediatric diseases, it's about mastering how presentation changes with development. In this part 2, I'm sharing more exclusive footage from our paid course. Actual teaching sessions revealing how students went from memorizing facts to thinking like top scorers. These aren't just pediatric principles, they're the age-based reasoning patterns that appear throughout Step 2. See how mastering this approach transforms every patient scenario into a question you can confidently solve. These are two of my favorite concepts that I use pretty much every single day in helping to transform what feels like this massive, massive amount of information into a tractable amount of concepts that you can use and apply to learn things faster, to retain it better, and to get more questions correct, even without knowing a lot more of actual fact. And so the condition that we're going to talk about first is pressure ischemia. We're going to use this in the context of tracheal stenosis and tracheomalacia when you've had intubation for too long. And so specifically, the core concepts are delta P equals flow times resistance, right? P1 minus P2 equals flow times resistance, and ischemia is demand greater than supply. Almost every single condition in medicine is going to involve one of these concepts, either delta P equals flow times resistance, ischemia is demand greater than supply, or acute versus chronic inflammation. And then after this, we're going to talk about biochemistry and two of my favorite conditions to talk about that in learning them can explain almost every single biochemical pathway in a way that will help you to learn it faster and to retain it better. But let's start by talking about tracheal stenosis and tracheomalacia. So an endotracheal tube, the key thing, right, if you intubate someone, the endo, meaning inside, tracheal, meaning trachea, the tube that you're putting inside the trachea, the key thing is that there's this balloon in this cuff. And that's the most common cause of the tracheal stenosis and the tracheomalacia, right? Reason being, you've got this balloon that's now pushing against the sides of the tracheal wall and then evacuating blood from this. And this ischemia that is being caused by this over time will cause necrosis that can either cause problems of the trachea being too loose, right, the tracheomalacia, or it causing chronic inflammation and fibrosis, which can cause the tracheal stenosis because you have this sort of overexuberant fibrosis response. And so again, the concept behind pressure ischemia is really, really simple, right? It's where you've got this external pressure, and so because of this, you're kind of pushing down, and it's evacuating blood from the capillaries, right? You're going to decrease flow from the arteries to the capillaries, and so there's going to be this relative ischemia. And if it happens over too long of a period of time, right? Because, for example, tracheal stenosis is one of those things that you worry about after intubation for over, like 2 weeks. And especially when you get to 3 weeks, you really start to worry about tracheal stenosis and tracheomalacia. And it's because of this idea of pressure ischemia, right? And so if you've got prolonged and high pressure, that is going to cause ischemia. This is why, for example, in patients that have undergone anesthesia for a really long time and they're sitting on the OR table, you've got to massage their heads, otherwise they can end up with bald spots, right? Because that pressure is going to cause ischemia. It's also the idea behind pressure ulcers and things like that. And then another really great concept that comes from this is the idea of inspiratory versus expiratory airway narrowing, which again, we're going to cover more in depth in the lessons, but I just want to give you a nice preview. And so there is basically two pressures that determine the relative opening of an airway. It's the pressure from outside of the airway, and then there's pressure from inside the airway. And so for the intrathoracic airways, right? So there's kind of this imaginary line where we've got the trachea here, and we've got the intrathoracic, meaning inside the thorax, and then extrathoracic trachea, and then other parts of the airways. On inspiration, what happens to the relative pressures versus external versus internal? Will the intrathoracic airways be more or less narrow? And so the idea is that on inspiration, you're going to have negative relative intrathoracic pressure. And so the intrathoracic airways are more open, right? In other words, it's kind of like on inspiration, right? You're kind of like pulling open these walls, and then relatively speaking, right, because the pressure here is going to be more negative, you're going to have more of the air particles sort of move in here, which means that there's going to be higher pressure relatively on the outside, and you're going to have relatively more of a collapse in the extrathoracic part on inspiration. And then for intrathoracic airways on expiration, what's going to happen is basically going to be the opposite. So again, we're going to go in more depth on this, but I just wanted to give you an overview, because these are pretty common questions that people miss, both for pediatrics as well as for internal medicine and sort of like the critical care portions. So if you want to do well on those things, I would highly, highly recommend that you do this, especially if you are also interested in things like anesthesia, surgery, critical care, or things of that nature. The final thing that I want to give you a preview on is biochemistry integration. And so this is one of my favorite topics to do, because most people like hate biochemistry, and they hated it for step 1, and then they also hated it for step 2 even more, because it's been even longer since you've studied these things. And so I want to show you how you can use just a few simple biochemistry principles to explain diabetic ketoacidosis better, and you can use something like von Gierke, which can help you to really integrate and apply a lot of these biochemical principles. And so, for example, you're going to learn about what does DKA actually mean biochemically. How does this occur, right? Where you've got too little insulin, and as a consequence, you are going to have your body is going to think that it's starving of glucose inside the cells. As a consequence, you're going to basically rev up the starvation systems, including making ketone bodies. And so you're going to have way too many ketone bodies, which as a consequence is going to create an actual acidosis, and then a lot of concurrent other problems. We're also going to talk about the activity level of each of these different enzymes. And so this is something that can sometimes come up even in biochemistry for step 2. In particular, it comes up in the case of pediatrics, so we're going to cover this. And then also talk about why it's more likely to happen in type 1 diabetes as opposed to type 2, right? Since it's really about insulin deficiency. And so this is why it's a really important thing to know for pediatrics. And then what the sodium level would be in someone in DKA, right? So understanding this can help you a lot with understanding hyponatremia in general, the different causes, and what are the cases of hyponatremia where you'd want to use hypertonic saline, and which are the ones in which you don't really need to, which this is one of the ones where you don't need to use hypertonic saline. And then what kind of fluids you would give to someone with DKA, right? We can use the pathophysiology to explain that. And then what is the total body potassium levels of someone in DKA, which overall it's going to be low, because again, you've got so much glucose that it's going to cause this osmotic drag and then pull out so many of the different electrolytes. And then in terms of the von Gierke, we're going to talk about cholesterol synthesis, gluconeogenesis, purine breakdown, fatty acid synthesis, and the HMP shunt, all of which you're probably like, oh my gosh, I thought I was done with all of these things. And quite frankly, you don't have to know so much of the details of them, but you do have to understand what the overall idea of the pathways are. And if you understand this, it'll make a lot of those rare pediatric conditions that like to show up on shelf exams and for step 2 that much more straightforward. So really excited to have you dive into this and to learn this at a much deeper level so that you can learn things faster and remember it better and to get higher scores in less time. So before we move on to the next concept, if you want to go deeper on these and other high yield topics, we have a free 14-day course that covers exactly what it is that we have found help students go from, in some cases, failing all the way to 260 plus. So be sure to click the link in the description to sign up. What we're going to do is, just with all of the pathophysiological chronologies, I'm going to read the vignette very slowly to show you how slowly you should read this in real life. Because again, if the only thing you take away from this is that your goal on your test is to read every single vignette only one time, and in order to do that, not only read it one time and to understand every word as you do it, right? In order to do that, you must read it slowly. So I want to show you how slowly I would read it on my test. So a 45-year-old woman comes to her physician with 4 months worsening dyspnea and intermittent wheezing. 8 months ago, she was intubated and mechanically ventilated for 2 weeks for management of Guillain-Barré syndrome. She takes no medications. Pulse oximetry on room air shows O2 sat of 97%. High-pitched and expiratory stridor are heard over her anterior thorax. No crackles are present. What is the pathophysiologic chronology? Why does she have expiratory stridor? Great. So what I'm going to have you guys do, so again, this is about as slowly as I read it on my test. I probably read it a little bit faster because it goes a little bit faster if you read it in your head, but this is roughly the speed that I read it at, literally. So I want you to make the pathophysiologic chronology in the Google Doc and we'll talk about it. So I was looking at your pathophysiologic chronologies. I'll give you another chance to write it again when we go over it at the end, but I want to tell you what mine was first. So intubated for prolonged period, right? Again, like a lot of you guys focus on the, like in this case, sure, you can talk about the pathophysiology, but it's not really that important. The key is that there was prolonged intubation. That was the important thing. I just needed to come up with some scenario in which someone was going to need to have a tube in their throat for a long period of time because you have the cuff that presses on the trachea. And as we learned last time, there is such a thing called pressure ischemia, right? So you're evacuating the blood flow from the capillaries. And so over a long period of time, or at least decrease in blood flow to the capillaries. So over time, you're going to damage the cartilage. So weakening up the cartilage. And so either, right, you could get tracheomalacia, which I guess could do this, or tracheal stenosis, but either of these things could happen. And so the key is that you're going to get collapse of the trachea on expiration, right? Because it's an intrathoracic structure. And so you're going to get expiratory stridor. So again, if you don't make sense of this now, right, before your test, it's not going to just magically make sense on the day of your test. So the best time, if you get to your test, if you ever get to an exam question and you're like, gosh, I don't understand what they're telling me, that's not a problem on the day of your test. That's a problem in your preparation. And so what we're going to go through is exactly how you should prepare so that you know exactly what the question means. If you know what the pathophysiologic chronology is on the day of the test, I would argue that it's probably going to increase the likelihood of getting that question right by at least 30 to 50%. That'd be my guess. It's a huge swing, right? It's like shooting a half-court shot versus like a layup. It's a huge difference. So let's talk about pressure ischemia or recap pressure ischemia. So the basis for pressure ischemia is there's some sort of pressure. That actually doesn't even necessarily, what you'll see is it doesn't necessarily have to be like external to the body, just external to the blood vessel. So there's some sort of external pressure. So mobility, an endotracheal tube, but it decreases blood flow to the tissue. And so because you have decrease in blood flow, you'll get ischemia and partial necrosis. The way to think about it is that again, like your capillary pressures are about like 20, 30. I think mean is like 16 millimeters of mercury. An endotracheal tube, right, can have a pressure of 20, right, or higher. And so if you're not careful, it could exceed the capillary bed pressure. So it's not hard to imagine that if you have an endotracheal tube in someone's trachea for 2-3 weeks, 2 weeks is like the cutoff in which you worry. 3 weeks is where you really start to worry about tracheal stenosis or tracheomalacia because of ischemia. Yeah. So Boogie, what pressure would you need to cause ischemia or tissue necrosis? How can you think about it? Because it's not one number, right? Like, how do you think about it? Boogie, what do you think?
I thought when we tubed a patient, we couldn't go over 10, anywhere between 7 to 10, but we couldn't go over 10 centimeters of water pressure, correct?
Oh man, Boogie, if someone needs to intubate me, I want you to do it. That'd be awesome. 10, yeah. Usually it's 20. Usually is what is the pressure that you don't want to exceed, if I recall correctly. Like the sad answer is that most anesthesia don't.
I remember it was 10 cc. You had to use a 10 cc syringe when we hooked it up to my tube.
Yeah. But the pressure is much more than 10 potentially, right? Like it's because pressure is
that's right.
A function of like how tight the trachea is, like how wide the tube is, all those sorts of things. So yeah, 10 cc's is usually what you use, but yeah, the pressure is they probably didn't measure the pressure. The only time that you like routinely, and I don't even know them routinely do it. The only time that I've kind of like quasi seen people routinely do it is in pediatrics, right?
Yeah, even when we transported patients in the air, because pressures in the cabin fluctuate as we're flying, I would actually leave and this is not typically done when you're on the ground or in the air, we typically leave the plunger of the syringe on the pilot cuff. Because if it starts to push back, that means that my cuff is actually getting bigger inside as we're climbing an altitude.
Interesting.
Yeah, so that's one of the ways that we know, oh, wait, I got to pull back because the cuff is inflating, climbing an altitude. Yeah.
That's really cool. The short answer is there's not one pressure, right? The idea that you have to remember ischemia, that like the amount of time that like ischemia like you need, it's a function of how much ischemia do you have. So if the pressure is higher, you'll have more ischemia, right? But also a function of how much time it is. A little ischemia over a long period of time is the same thing as a lot of ischemia over a short period of time, roughly. You can model it that way. So that's why you can have ischemia after a really short period of time if the pressure is high enough. But you can also have ischemia, like in the case of an endotracheal tube, even if it's like, you constantly checking the pressure or stuff like that, you can still get ischemia over a long period of time, right, if it's long enough. Great. So of the endotracheal tube. So this is endotracheal tube. Brandon, which part of the endotracheal tube most commonly causes tracheal stenosis or tracheomalacia? Yeah.
Would it be the bulb?
What's the bulb?
Like at the tip of the screen? Yeah. Oh, yeah, that where your arrow is pointed to.
Yeah, exactly. Yeah, we call it the balloon or the cuff. So this is a cuffed endotracheal tube, right? Because this thing. And so why is there a cuff? Do you know?
Is that to keep the airway open, or?
This is pretty like thick, hard plastic. So the airway is not, I mean, like the airway doesn't collapse on itself. The trachea is a pretty rigid structure. The airway shouldn't collapse. I have a cuff.
Is that for pressure?
I don't know. What do you mean pressure?
Like measuring pressure, or?
I guess you could. I guess in theory, but no. The major reason is that you're going to prevent, right? Because you're sticking this tube into someone's throat and you're going to leave it here. So the cuff prevents, like, you make tons of secretions in your mouth. So those secretions, like spit, saliva, are going to go into your trachea. And so the cuff will prevent those things from going into the lungs. That's the major reason. And I guess it secures it a little bit, but you extra secure it. But yeah, the big thing is that if you have a cuff, then anything that goes down into your trachea, you're protecting the airway. And so remember, there's 3 reasons to intubate someone, right? Ventilatory failure, meaning your CO2 is too high, oxygenation failure, meaning your oxygen is too low, but also airway protection. And it's that third thing that's for the cuff, right? The cuff is there to protect the airway. All right. So again, this is the general model of pressure ischemia. You've got arteries and capillaries. And so, right, I've got some sort of external pressure. So in this case, it's the cuff from the endotracheal tube is pushing literally on the tissue. And so that compresses the capillaries and the arterial flow. So over time, that ischemia is going to cause problems, either tracheal stenosis or tracheal malacia. So prolonged/high pressure will leave you ischemia. That's it. So Danielle, what is stridor?
It's like a high-pitched sound.
So it's defined variably, but yeah, one definition of a loud musical sound of constant pitch. I think technically wheezes, I don't know that my ears are this good, but wheezes, I think, are like polytonal. I think stridor is technically monotonal. It's just like one pitch, which makes sense because it's like a single structure that's making it, or it's like a single frequency, as opposed to like wheeze is like multiple different things are giving you a wheeze. It's not like it's multiple airways. So different resonance frequencies. So versus a wheeze, Deb, what is a wheeze?
It's also a musical sound. Patients.
Yeah, the times that you see it are different. Yeah, so it's high-pitched continuous. Yeah, so it's because of smaller airways, because of the airway oscillator. So they're very similar, though. And technically, I used to think that they were actually different. Technically, I think stridor is a kind of a wheeze, which is interesting. So again, bolded, important to understand. So Hadra, how could you connect the size of the airways in which you'd see pathology to which would lead to which?
Wheeze is when it's in the alveoli and when the size of the
Probably alveoli,
no, it's
right?
sorry, bronchi.
Like crackles.
Yeah. The bronchioles, and when they're narrowed like in asthma, yeah. And stridor is, I guess, in the trachea when it's obstructed.
Makes sense.
Yeah, it makes sense because there's one trachea, you're going to have a single constant pitch, a monotone, and wheezes, the bronchioles all have different sizes. So maybe that's why we have the varied kinds of sounds.
Yeah, exactly. Yeah. I like that explanation so much. I'm actually going to change what I wrote. Yeah. Yeah. So it's one single airway, which should give you a single pitch. If you've ever played recorder, right, in middle school or elementary school or whatever, like it's one pitch, right? A flute gives you one pitch. But now you have like a slightly different, like 100 different sized recorders, all slightly different sized from each other. They're going to give you different pitches. Yeah. So that's the way that I would make sense of why you get one in one and not the other, or why there's one pitch in one and not the other. Great. That was awesome. All right. So Jared, there are 2 pressures that determine the relative opening of an airway, right? So there's the pressure from the outside and there's the pressure from the inside. So as diagrammed here, my wonderful diagramming skills, right? So there's the pressure coming from the inside. So this is my airway, solid line. And then so there's the pressure coming from the inside and the pressure coming from the outside. So Jared, for the intrathoracic airways, so again, so intrathoracic is here, extrathoracic is here, right? So the extrathoracic portion of my trachea would be here, the intrathoracic portion would be here. So to inspiration, what happens to the relative airway pressures, the external versus the, and will the intrathoracic pressures, would intrathoracic airways be more or less narrow?
For the intrathoracic, when you inhale, you're decreasing pressure, I think, in the cavity. So you would within the thoracic cavity.
So
or I guess
external airway pressure or the internal airway pressure?
So external airway pressure, I think you're decreasing. So you'd be pulling, and then you would create more pressure on the internal, I think.
Good. Why?
Because as the diaphragm moves down, you're going to create a vacuum. So it's going to seek to expand and fill that space by pulling air in from the outside, and it'll create a higher pressure in the trachea than outside the trachea, within the thoracic cavity.
Kind of. I don't know that I quite agree with all the words that you just used, definitely with the outside. So that explains why the outside pressure, right? The extra it's a little complicated, but the extra tracheal intrathoracic pressure, think about that for a second. Extratracheal, right? Outside the trachea, intrathoracic pressure, that should be lower, right? Inside, you can think of it as higher because, yeah, it should be higher relative to the extra tracheal pressure.
It's normalized to the outside, but like relative to the thoracic cavity, it's a higher pressure.
Yeah, exactly. Because relatively speaking, but even relative to what it had been before, it should be higher, presumably. Actually, I don't know about that. Yeah. Let's go with our first explanation. So the negative intrathoracic pressure, so the intrathoracic airways are more open. And so these are going to open more. Yeah. So on expiration, then Luis, on expiration, what happens to the relative airways pressures, the external versus the internal? Will the intrathoracic airways be more or less narrow? We'll go to Mahana next.
On expiration, I think the extrathoracic external pressure would be increased so that it will push on the trachea and it will collapse.
Good. That is correct. Yeah. The extratracheal intrathoracic pressure should be higher. So then it should be smaller. Hadra, what's your question?
Yeah, I actually don't get this. Which one's intrathoracic and which one's inside the alveoli?
So intrathoracic and intraalveolar pressure, they will equalize, but technically they're not necessarily going to be the same. Why do you ask that question?
I just got confused with this, Alec, that we're saying that intrathoracic pressure is the pressure that builds up when I inhale, and the extrathoracic pressure...
Be careful. What do you mean? Builds up when I inhale.
That is inside my alveoli when I inhale?
No, think about this as your trachea. Think about this in terms of like your trachea, because that's really what we're talking about here. So if I inhale, the pressure actually in my intrathoracic cavity decreases. That's the point. So your trachea, if anything, is going to expand slightly, but your intrathoracic airways are all going to expand slightly. When you exhale, right, your intrathoracic airways are all going to collapse. This is why, we'll talk about this, but this is why asthmatics, right? If you're going to get a wheeze, it's going to be on what? Inspiration or expiration? It's going to be an expiration. So good. So let's go to Nathan next. So let's talk about the extrathoracic airways. We just talked about this one. Inspiration, the intrathoracic airways expand. Next, expiration, they're going to collapse. So what will happen to the extrathoracic airways on inspiration, Nathan?
I assume it would be the opposite of so if intrathoracic goes down, extrathoracic would go up.
Yeah, essentially. And in this case, I think it actually has more to do with, because you're not really changing the extrathoracic pressure. Really what you're doing is you're changing the intratracheal pressure, because you're basically like sucking air out of your trachea, and so you're decreasing the pressure inside of your trachea relative to the outside. Does that kind of make sense? I'd love to think that I'm really strong, but like I'm not changing the atmospheric pressure when I inhale. The atmospheric pressure is really what determines my extrathoracic pressure. So really what I'm doing is I'm just changing the pressure inside my trachea.
So could you say extrathoracic pressure is responding to the intrathoracic?
No. The difference between my extrathoracic pressure and my intratracheal pressure is just when I inhale, the difference is the net pressure is going to be for my trachea to collapse. That kind of makes sense. Like when I inhale or exhale, I'm changing my intrathoracic pressure. I'm actually changing the pressure itself inside my thorax. When I inhale and exhale, I'm not actually changing the extrathoracic pressure. I'm just changing the pressure inside my trachea. So if the pressure inside my trachea is less than outside the trachea, what will happen?
Air will be sucked in.
Yeah, air will be sucked in, but also the trachea will, because it'll collapse slightly. Right. How about if the pressure inside is greater than the outside? What'll happen?
Air will be pushed out, and I guess the trachea will expand.
Exactly. But yeah, exactly. Good. Does that make sense?
Yes.
Yeah. So on inspiration, this is what happened. You get net movement in. And so so why might the extrathoracic intratracheal pressure be lower in inspiration? We already talked about that, right? You're essentially creating a vacuum within the trachea. So air is going to move into the trachea from the outside. So Paula, on expiration, what happens to the relative airway pressures? And will the extrathoracic airways be more or less narrow?
So you're expiring, and then when you expire, as we said, the trachea would expand. So right?
Yep, that's right.
Isn't that what we just said?
Well, the extrathoracic trachea, again, you have to be careful which part of the trachea you're talking about, but yeah.
Did I answer the question?
Yeah, the extrathoracic, so the extrathoracic airways are more open on expiration. So this is all to build up. So any questions so far? Because what we're building towards is, because like you'll see those things where it's, if they have inspiratory stridor, like it's bad, but if it's like expiratory stridor, it's like really bad. Maybe you've heard that. One is an emergency, one is like an emergency. Like we're building towards like, why would that make sense? So
So when you say extrathoracic, when you say is that at the level of like at the level of the collar where the thoracic inlet comes in, like with the word?
think of your thorax, right? Anything outside of it.
Yeah.
Good question. All right, so Priyanka, so if you had an extrathoracic airway tumor, right, because this is where this comes into play, would this produce a wheeze or stridor? And would it be on inspiration or expiration, and why? All right, Ruru, what do you think?
So I think this would be, if it's an extrathoracic airway tumor, I believe this would produce a stridor, and this would be on expiration, I think. So I'm thinking because the stridor would be in the trachea, so not involving any of the smaller airways. So it would produce more of a monotone sound, like we said earlier. And then on expiration, I think because it would be within the intrathoracic would be a higher pressure, and then it'd be pushing air out into the extrathoracic portion.
And the reason is on an inspiration, remember on inspiration, the extrathoracic airway collapses. Because in inspiration, my intrathoracic pressures last, right? So your trachea on the inside of your thorax should expand, but on the outside, it's going to collapse.
Better to think about this more based on like pressure differences than narrowing.
Yeah, essentially, because the narrowing happens because of the pressure differences.
Switching it like narrowing, then pressure difference, but it's pressure difference, then narrowing.
That is definitely true. Yeah, it's not the other way around. Good point. Yeah, great. Yeah, exactly. Yes, very good. Yeah. So then let's go to Amber. What do you think? So if you had an intrathoracic tracheal tumor, would this produce a wheeze or stridor? And would it be on inspiration or expiration? Why?
So intrathoracic, so that would be likely a wheeze.
Why does that make sense, like from a physics standpoint?
For it to be in that area, or for it to be a stridor.
Bronchial area to give you stridor and not wheeze.
Because when it's in the tracheobronchial area, the reason you get stridor is because it produces an obstruction. There's an obstruction in one of those areas. So you get, as we said, one of the gals said on the other page, it's a continuous sound, like a turbulent sound that you get in that area.
True, but a wheeze is turbulence too, right? Also from a relative.
Yeah, but aren't they usually from outflow obstructions?
True, but I mean,
actually, sorry, then stridor then actually is too, but can be.
So why one? I used to sing a lot, so like I thought about this stuff a lot, but I still couldn't make sense of it. So yeah, why does that make sense? Again, like I would present to you we'll call it the recorder and the recorder model of airway noises, right? Recorder meaning like the little wind instrument that you play in elementary school. So in the case of a tracheal obstruction, how many recorders are making a sound?
One.
Yeah. In the case of a wheeze, how many recorders are making a sound?
Several.
Lots. Like how many small airways are, right? But when I'm an asthmatic, it's not like one bronchiole that's like obstructing. It's like literally thousands of bronchioles that are obstructing, all of which are slightly different sizes from each other, which means all of which are going to have a slightly different pitch. That makes sense. So yeah, so that's why, because in the case of a large airway, right, there's only one thing that's going to be obstructed usually. So it's only one recorder that's making a sound. It's making a loud sound, but it's only one. There's only one pitch, right? For a wheeze, you have many pitches. And again, the reason is because you've got lots of airways that are being obstructed all at one time. So I like it. So Boogie's saying it's like stridors. Yeah. Go ahead, Amber.
So to answer the rest of the question then, so we're agreeing intrathoracic stridor. So does that mean then it has to be on expiration?
Yeah, it is. Why?
Because on an expiration, that airway gets more narrow. And so if there's already an obstruction there, doubly narrow, it's extra narrowed if you want.
Yeah, so that the airway is smaller, or the intrathoracic trachea is smaller on expiration, we already discussed. And so if it's already obstructed, then that extra narrowing can risks causing like a real obstruction that you'd hear. Does that make sense? Cool. All right, so let us go to Sujith next. So Sujith, can you tell me, for a wheeze, tell me like the kind of airway that we see it in to explain whether it would be usually expiratory, inspiratory, or both.
Usually it's like expiratory.
Yeah, almost always, right? Now tell me why.
Like what you said, since it's in the intrathoracic region, there's a chance of the area being collapsed. So I guess that's one reason why there's an expiratory wheeze, because inspiratory kind of expands when in expiration collapses or decreases in volume.
Yeah, that's the major reason. Yeah, because it's in the small areas, all of which are intrathoracic, right? You have no small airways that are outside your thorax. So it's going to be expiratory, since the intrathoracic airways are most narrow during expiration. Right? If I'm going to collapse, I'm most likely to collapse during expiration. So then Susanna, if you heard an asthmatic, if you heard wheezes on both inspiration and expiration, what would that tell you about the severity of the disease and why?
That is pretty severe.
Yeah, it's like super severe. Why?
Because it's like very obstructed. I like the alveoli.
Yeah, but why? How do you know you're really obstructed?
Because you hear, I don't know, like more wheezes because of the increase of pressure. Because you are like collapsed.
What happens to your intrathoracic airways on inspiration? Are they bigger or smaller?
They open.
They're open.
They're
Okay,
bigger.
in other words, they're open relative. So if they're open, if they're the most open that they could possibly be, and you're still hearing wheezes, what does that tell you?
Like a chronic thing.
No, it means that it's really bad.
I don't know.
If I fully dilate
Okay.
and they're still too narrow, that's bad. Does that make sense?
Yeah, it does because it kind of opens more. Like it cannot really open more. It's like at the max.
Yeah. Yeah, exactly. If you think about it, this picture wasn't made for this purpose, but let's say that like on inspiration, your airway was this small. That's really bad. But small enough to produce, let's say on inspiration, it's this small. The airway is this small. That's bad. That means it's really small. If it's narrow enough on inspiration, because on inspiration, it should be the largest possible. But if on inspiration, it's small enough to wheeze, that's a bad sign. Yeah. Like asthmatics where like you don't hear any air movement, that's really bad. And then you stop hearing wheezes, but you don't hear any air movement, that's worse. It's really bad. So, cool. Does that make sense?
Yeah, it does. Like in expiration is gonna be even more narrow.
Great. Amber, epiglottitis. Will epiglottitis lead to stridor or a wheeze? And will it be inspiratory or expiratory? Why?
So a stridor and expiratory.
Stridor and expiratory. Great. Why?
Epiglottitis, obviously, as it sounds, inflammation of the epiglottis. And so that is extrathoracic. And that is obviously the closest to a large airway space. So that's going to produce a stridor and expiratory because as you expire, you're collapsing the airway. There's already something that's inflamed bigger. So
An inspiration, you have to ask yourself, is it extrathoracic or intrathoracic? Because whether you collapse, it doesn't always collapse in inspiration.
I guess then I'm saying it's extrathoracic.
So when does your extrathoracic airway collapse the most? An inspiration or an expiration?
Expiration.
So it's inspiration, right? So we'll go back. So it's an extrathoracic lesion, right? So as you said, so we got that. So extrathoracic. But remember, on inspiration, the extrathoracic portion of your trachea is most narrow. Like you can think about it, right? Because there's, let's see, because it's collapsing because you're creating a vacuum inside of, you're creating like a vacuum inside of it. That's literally like why air is moving into your lungs in the first place. Does that make sense?
Yeah, no, I'm just trying to visualize, because when I think about what happens when you inspire and expire, I'm always relating it to atmospheric pressure and whether it's going to be negative or positive. So I'm just trying to wrap my head around more or less. Does it narrow or does it expand on inspiration or expiration? That part of the equation seems a bit new to me.
No, we can talk about it in your terms, right? Relative to like, because this is actually probably the best way to talk about it. So does air move into your trachea on inspiration from the outside?
Yes.
Okay, great. Why?
Because you have a negative pressure in comparison to the atmospheric pressure.
Yeah, exactly. So what do you think is going to happen to your trachea, at least your extrathoracic trachea, on inspiration, right? You just said there's a vacuum inside of your trachea, inside of your extrathoracic trachea, all of your trachea, but in this case, it's your extrathoracic trachea that we care about. So it should collapse. That should make the most sense. What's a little strange in some ways is like, why does the intrathoracic trachea expand? That probably makes a little bit less, maybe. I don't know.
Yeah, I don't want to hold the rest of the group back with this because I just have to think about this for a while. Because in my mind, I guess what I'm thinking about is when you expire, the alveoli have a tendency to want to collapse at some point. So you have surfactants, et cetera, et cetera. So in my mind, I guess I'm thinking that the trachea should be the same thing. That when I expire, that airway or that tube rather should want to get smaller and almost collapse on itself. So I guess that's why it's actually backwards.
What you're saying is true if you consider intrathoracic airways. The problem is that I think you're conflating intrathoracic and extrathoracic, right? You're thinking that thoracic airways should respond the exact same way that the intrathoracic.
Yes.
That's not true. It's actually the opposite. That's the problem. Because you're right. On expiration, your alveoli collapse, right? Because is that intrathoracic or extrathoracic? Great. On expiration, your small airways also collapse. Are your small airways thoracic or extrathoracic? Yeah, exactly. So yeah. The problem, I think, is that you're conflating intrathoracic with extrathoracic. You're expecting that your extrathoracic, your epiglottis, should respond the exact same way that your alveoli should. But that's not true. Cool. Cool.
So then back to your original question that you asked, sorry. So epiglottitis, I was saying stridor, that's fine, but I was saying expiratory when it should be inspiratory.
Yeah, because in your model, if you model them all like the alveoli, you're going to be right half of the time. You're going to be right only for the thoracic ones.
Right.
Yeah.
I think it was just me confusing, like you said, thinking that intrathoracic was going to be the same as extrathoracic when it's not.
But in tracheomalacia, maybe this case, right? So you intubate someone for a long time, they get tracheomalacia. So will this lead to stridor or wheeze? And will it be inspiratory or expiratory? And why? The tracheo, malacia means soft.
I was assuming it's maybe a sequelate to maybe some sort of ischemia or necrosis. I assume it's happening. So if that's the case, then I'd assume that maybe after all the inflammation is gone and over with, then now you have less tissue in the region. So because of necrosis, so most likely the airway is slightly larger.
Oh, so the problem in tracheomalacia is that it's sort of like bronchiectasis, actually, in terms of physiology, in the sense that it's a dynamic. You would think that bronchiectasis would cause, like, you'd have no problems because it's like the airway is larger. Ectasia means dilation, but it causes expiration. It causes expiratory obstruction, right? Expiratory wheezes. You've lost the rigid structure of the airway, and so it collapses.
Yes, gotcha.
Yes, you are correct. It would be slightly larger than normal, most likely. The problem, though, is that it doesn't stay open.
It's floppy.
So anyway, so would it be inspiratory or expiratory?
I assume that if it's following intubation, if it was secondary to the intubation, it's probably happening just inferior to the cords. So it's still high up on the airway. Now, if you're having a collapse, though, up there, it's most likely a large airway obstruction. So weren't we saying now that this is typically going to be an inspiratory problem?
So it's actually expiratory. The reason, I love your reasoning. If you look, though, I don't know if we talked about, I think we talked about this maybe last time. Remember that when you intubate someone, it's pretty deep in there. So when you intubate someone, it's in thoracic. That cuff is intrathoracic, right? And it's not actually just past the cords, right? It's like reasonably past the cords. It's supposed to be like up to 3 centimeters from the carina. So this is like the end of the tip, right? So it's like here, but it's pretty intrathoracic. So Boogie, if it is intrathoracic, what do you expect?
So if it is intrathoracic, then most likely it's going to be like you mentioned, it's going to be an inspiratory problem. Is that what you said? I'm still confused here because if we're having a problem with a large obstruction, so let me just go back to thinking how we're thinking of wheezing, right? So if we're thinking of wheezes are typically intrathoracic. So if it's intrathoracic, I'm using here wheezing on expiration. So in this case, since we're equating this to an intrathoracic issue, then it's obviously going to be on expiration.
Oh, love it. That was good. I like that. Yeah, you were relating it to something. That's good.
Yeah.
That's probably what I would do too. Like anchor on something that you're sure of. Asthma is expiratory.
Forgive me for my limited experience, because usually when I tube someone, once I see the balloons past the cords, that's where we in the field stop.
True. Yeah. In fairness, that's what most anesthesiologists do too. But even then, I think it's probably still intrathoracic. Right? I mean, think about like your cords. Your cords are pretty, I don't know. I guess I don't actually know exactly where the cords are relative to the external anatomy. That's fair.
The cords are just going to be just below the Adam's apple, doctor.
Yeah. I guess maybe you could, maybe in theory, but no, when you do it, because when they do an ice intubation, you're supposed to do a chest X-ray afterwards because you're trying to find the tip. I think it's 3 centimeters above the carina. But yeah, Brandon. So in asthma, will this lead to stridor or wheeze, and will it be inspiratory or expiratory?
For asthma, since it's mainly focused in the intrathoracic region, so you would expect wheezes with expiration.
Yeah, good. I don't know that I followed all of your reasoning. So that it is intrathoracic does not mean that it is a wheeze, right? That it is intrathoracic would mean it's on expiration. Totally agree with you. But you can have intrathoracic, like large airway obstructions too. But I want to give you another chance to explain your reasoning.
Because we're talking about like the stridor happening with like the larger airways versus the wheezing, happening with the smaller airways.
Totally.
Yeah, which relates to the asthma with like the bronchioles.
Exactly. Yeah. That would be the reasoning that I would use. Yeah, asthma is a small airway problem. In this case, it's like thousands and thousands of little recorders. There's slightly different sizes, and each of them produce slightly different pitches. So that's a wheeze, right? That is a wheeze. And that it is intrathoracic would mean it's expiratory. Excellent. Great. That's awesome. Yeah. Thanks. All right. So let's go to Shama. So laryngomalacia will typically to stridor or wheeze, and it will be inspiratory or expiratory. And why?
This would be a stridor, wrong or right, if we're move on.
Yep, you're right.
And then since it's intrathoracic,
Starting stridor.
because it's in the, like, it's by the trachea, it's not in the alveoli. That's how do I say it? It's a large airway.
Yeah, there's a wide range of things that something can be between like large airway and alveoli. Like in between a large airway.
So since large airway, it's a stridor, and then I would say hold on, this is extra thoracic.
So the question is, where is
Yeah, it's extra thoracic because it's in the larynx, which would impinge on the trachea. So this would be an inspiratory stridor.
Yeah, that's right. Cool. It's an extrathoracic. Yeah, it's extrathoracic, which means that your extrathoracic areas are most narrow on inspiration. Exactly. So Danielle, so if you had foreign body aspiration, what's your question? Will it be stridor or wheeze, and will it be inspiratory, expiratory, and why?
I guess is the foreign body in the lungs?
Here we go. Yeah, that's the question. Yeah, so it just depends on where it is.
Yeah. So if it's in the lungs, it would be intrathoracic. So then it would be wheezing and associated with an expiratory wheeze. Oh, I guess, yeah, because it wouldn't be affecting the small airway. It's true. It's
even if technically it did affect the small airway, this would be like the time where technically I think it would still be considered stridor, because again, unless you're aspiring, right? Or aspiring? No. What's the verb for aspire? Aspiration. You undergo aspiration. Unless you have like aspiration of tons of little things, right? Like it's only one thing. So there's only going to be one recorder, so to speak.
Yeah, that makes sense. So it's going to be a stridor, whether it's intra or extrathoracic.
And you said if it's intrathoracic, so if it goes down into your like littler airways, you're less like not. Then what would it be?
That would be an expiratory stridor.
Yeah, good. Yeah, very good. Yeah, very good. Yeah, so it depends. So if it's intrathoracic, yeah, it's expiratory. If it's extrathoracic, right? If it's in the larynx, it's inspiratory. I think I may have misspoken before. I think that, because I'm trying to think, the kind that you worry about, it's the weird rules. I think technically the one that you most worry about is actually the extrathoracic one, technically. If I had to choose, what am I going to obstruct? It would be, I think you worry most about expiratory. So I'm going to check that. But I'm pretty sure that it's the extrathoracic one you worry about. And the reason is because you're blocking like all air movement. If I block, like, in other words, if it's an extrathoracic obstruction, right, like larynx or trachea, then no air can move, period. Like one of the things that they teach you is that if you can't get something out, you want it to at least go down so that it's not blocking all of the airway. Just push it into a smaller airway. So I actually think that it's worse if it's extrathoracic. So I think I may have misspoken before. I think I may have said that expiratory stridor was worse, but I actually think it's inspiratory. But someone check me on that. He says, or you can slice the crike. Sure, that is true. But again, that's only going to matter if it's wet. Right? Sticking a needle in someone's crike or pyrothyroid membrane. Like, when would that work and when would that not work?
That would only work if the obstruction is still anterior to the cricothyroid membrane where you're slicing. If it's after that, or you're still kind of
proximal to it, then it works.
Yes.
If it's distal, it doesn't.
That is correct. You're still at a roadblock.
Yeah, exactly. Yeah. You're just going to stick something into, just like proximal to the obstruction. So let's go back to our vignette. So again, we'll go back to the Google Doc. I'll have you write out your pathophysiologic chronologies, and I want you to, and we'll talk about it in a little bit. Cool? All right, thanks, guys. I'm just going to go through and look at some of these. So let's look at Danielle. So previously healthy female to LSU, yes. Antibody, good. Paralysis, respiratory failure, good. So mechanical ventilation for that, good. Balloon cuff pressed on the trachea, tracheal compression, tracheal malacia. Yeah, I guess I'd talk a little bit more about why, right? Because it's like black boxing it. And tracheal compression leads to tracheal malacia. It's because of pressure ischemia. Pretty simple. Long period of time. So intrathoracic obstruction. So it affects the large portion of the airway. Stridor on expiration. Good. It's an extrathoracic on expiration. I would say an intrathoracic cavity. I guess technically I guess that's true. The cavity. But really I would think about it as like intrathoracic airways. There forces air out. Airways narrow due to trachea. Good. Yeah. It causes dyspnea, but also it's going to cause the stridor. So good. Boogie. So previous endotracheal tube, hyperinflated cuff. Again, it doesn't even necessarily have to be hyperinflated cuff, right? Like normal, like at 2 weeks is like the time at which you really start to worry. That's why if you ever like in the ICU, they'll talk about at about a week, they're like, oh man, should we give them a tracheostomy? Should we give them a trach? Oh, I don't know. But what they're thinking is are we going to get to the 2 week mark? Are they going to be intubated at 2 weeks? Because if they are, we should probably give them a trach early to reduce their risk of having tracheal injury from pressure ischemia. So yeah, tracheal, yeah. So long-standing tracheal cuff, intratracheal pressures. Good. Yeah, mucosal ischemia, tracheal necrosis, good. Tracheomalacia, yeah. I don't know if it's necessarily tracheomalacia. This is either tracheomalacia or tracheal stenosis. We don't actually know. Tracheal collapses up, symptomatic pressures on inspiration or broncho. So again, it's not bronchoconstriction. Constriction means that there's something like, there's actually something that is constricting, right? Like muscles that are contracting. That's not true. You're not contracting the bronchial muscles. It's that you are compressing them. They're collapsing because of increase in external pressure. So decreased integrity of tracheal walls, floppy airways. Yeah, maybe some mucus production, but yeah, really it's expiratory sphincter. Good. That's good. Yeah, perfect. So let us go back to our vignette. And so I will tell you what my pathophysiology, again, I think a lot of yours are often better than mine, but I'll tell you what I would have said. So the detailed one would be that she has GBS. So she has diaphragmatic paralysis. That leads to respiratory failure. So she was ventilated for 2 weeks or longer. I don't think I included that in the actual vignette, that it was 2 weeks. But yeah. Oh, no, I did. Yeah, 2 weeks. Yeah, 2 weeks is the cutoff. 3 weeks is when you really worry, but 2 weeks is when you start to worry about tracheal stenosis or tracheomalacia. So ischemia to the cartilage, so weakening of the cartilage. So you get intrathoracic. It's either stenosis or tracheomalacia. That's the key. So it's a large airway, so it's stridor, and it's intrathoracic, which means it's going to be expiratory. So you get expiratory. All right. So I want to open it up to questions because I know that I didn't do a great job of explaining this. It's confusing, actually. Like I went through all of an anesthesia residency, and like I still get these things mixed up. So if you're still like, oh man, I don't know, that makes, you're normal. But I want to give you guys the chance to, or I want to give myself the chance of clarifying before we finish on things that I didn't explain very well.
I have a question then, Alex.
Please.
So I guess maybe going back to the question that I posted in the chat. So if we do have a collapse in the airway on expiration, would that provide us some sort of peak expiratory end pressure to maybe even perhaps keep some of that lower airway open if we had issues?
Yeah, probably. You're saying in asthmatics, do they have a decreased risk of having like atelectasis? Probably. Yeah. I never thought about that. You're treating one problem for another, but yeah, I guess that's probably true. Yeah. Because you are giving them, yeah, you're like literally trapping air. The whole point is that you're like literally trapping air in the airways. That's why you get like the barrel chest and COPD. So yeah, I guess so. I thought about it that way, but yeah, you like an asthmatic shouldn't really have atelectasis. Like you don't see barrel chest and atelectasis. So yeah, I guess that's a good question. Other questions?
Alec? Yeah, so there's one thing I'm always confused about, and that's when we inspire, we're decreasing our intrathoracic pressure.
Yes.
If yes, how? Why?
So think about your diaphragm, when it contracts, it will flatten, right? So if you think about it from a physics standpoint, pressure is just air particles per volume, really. So you have when your diaphragm expands, what's the volume in your intrathoracic cavity? Is it larger or smaller?
When the diaphragm, you mean when the diaphragm is going?
When the diaphragm descends. So when I breathe in, right, when I inspire, it's because my diaphragm is descended.
Yes.
Right. So when my intrathoracic volume, is it increasing or decreasing?
It decreases unless you care.
It increases. So when I take a breath in, right, I increase the volume in my thorax. Literally, I'm pulling down on my lungs because they're attached to the pleura. So my diaphragm descends, and so my lungs are literally like being forced open. They're literally being pulled open. So again, pressure is just air particles per volume, right? So the number of air particles is staying the same, at least initially, but my volume is now increased. So my pressure has decreased inside of my thorax.
So can I say that when we inspire and the diaphragm descends, a vacuum is created?
That's exactly what happens. Yeah. Yeah. This is something that I was always confused about.
Yeah. Alec, the wall of the thorax, the bones and everything, the thoracic cavity is basically augmenting that decrease in pressure?
Yeah. So I was saying, you're always taught to breathe from your diaphragm. I don't know if you guys like yoga, they say that too, or like sort of breathing exercises, they say breathe from the diaphragm. But yeah, if you use your accessory muscles, really what you're doing is you're expanding your thorax outwards. Like you're expanding your chest wall or upwards, up and out a little bit. Yeah, but the general idea is that you're basically trying to force the lungs, right, to expand. And by forcing them to expand, you're decreasing the pressure inside of each of the airways relative to the atmospheric pressure. So air is going to rush in because there's fewer air particles per volume inside the lungs, and there's more air particles per volume outside the lungs. So that is a vacuum, right? It's just, you're talking about relative pressures. So the relative pressure inside the lungs is less than the relative pressure outside the lungs.
Got it.
Does that make sense?
Yeah.
Yeah, I mean, think about it sometime. But just sit there and breathe. If you're breathing with your diaphragm, the way that you know is that your belly expands. The reason that your belly expands is because your diaphragm is descending and it's literally pushing all of the abdominal contents. It's squeezing all the abdominal content. So they got to go somewhere. So they expand outwards, like anterior. So yeah, it's fun. It's fun to think about.
When the intrathoracic pressure decreases, the venous return, what happens to the venous return?
Yeah, it's just a pressure differential, right? The pressure in my vein stays the same. My pressure inside my thorax goes down. So yeah, the pressure differential. It's different. The confusing thing is that it's different on when you've intubated someone. When you've intubated someone because when you intubate someone, the mechanism is different. You're literally increasing you're increasing the pressure outside of the body. That's how you deliver air in. Right. Normal breathing is you decrease the interthoracic pressure so that you create a vacuum. A ventilator means that you increase the extrathoracic pressure, that you increase the atmospheric, essentially the atmospheric pressure so that you force air in. So it's, yeah. But yeah, for a normal person, if they're not mechanically ventilated, then yeah, on inspiration, your venous return should.
Got it.
Awesome. Thanks, guys. I will see you next week. All right. Take care. Okay. So today I want to talk about diabetic ketoacidosis because I think that, again, this is a really, really, really good way to tie in biochemistry with a lot of different other subjects. So even if you haven't studied those other subjects, I think that we can talk about it in simple enough terms that you should be able to understand it. Okay. So again, with every single lecture, I always start with the questions that I want you guys to come away with, right? If you understand the answers to these questions, you really, I think, will understand all of the underlying basic information. So in other words, like instead of having to sit there and memorize the entire TCA cycle, if you understand if you're able to integrate it and apply it along with other concepts, you won't have to sit there and memorize it. You can actually just use these questions to help remember it and to learn in a way that's going to be applicable on your step one. Okay, so the questions you can see here. Let's just get going. So why is it called DKA? So Jeff, why is it called DKA?
Because then you know that it involves patient and diabetes, and then it's involving with ketone and a metabolic acidosis.
Yeah, and why do you get a metabolic acidosis?
Because the pH in your body will be less than 5.3.
That's true, but that's just saying like, oh, it is because it is. I'm asking what is producing the fact that the pH is less than 7.3 or 7.5?
Are you producing a lot of hydrogen protons?
But why? Why in DKA are you making a lot of protons?
Because the ketones are having to dephosphorylate, so they're more acidic, and so it pulls a lot of ketone.
Yeah, exactly. Ketone bodies themselves are acids. Aparna, what are the two major ketone bodies?
It's acetoacetate and beta hydroxybutyrate.
Perfect. And those are the deprotonated forms. So what's the difference between lactic acid and lactate, Daniel Schlesinger?
Lactic acid has a carboxylic, a full COOH. The other lactate is missing the hydrogen.
Perfect. Yeah. So the difference between so I didn't know that. It's funny. I was a chemistry major, and I don't think I figured this out until medical school, which is a little embarrassing. But anyways, so COOH, right, the carboxylic acid group, it means it's an acid, right? So that's like lactic acid has a COOH. Remember C-double-bond-O and then the OH. So that if it has the H there, it is acid. So lactic acid has a COOH. Lactate, right? So lactate, as opposed to lactic acid, lactate is COO, but there's no H. So it's the COO minus, if you guys remember back to organic chemistry. So acetoacetate is the same as acetoacetic acid. The only difference is that it lacks the hydrogen group, right? It lacks that proton. The proton is dissociated, as Jeff was saying, right? So beta hydroxybutyrate is the same as beta hydroxybutyric acid, with the difference being that you've lost the proton. So again, all of these things are just acids, right? There's nothing special. You're overproducing all these ketone bodies, and so you're getting an acidosis. So does it happen more in type 1 or type 2 diabetics? Omi.
I think type 1 diabetes.
What? Okay, now why? That's the hard one.
I think with I think it has to do with like the insulin in sense, like it's complete lack of insulin in type 1.
As opposed to type 2? Why? So why wouldn't you get in type 2?
Because they still have a little bit of insulin being secreted, and that's, I guess, enough to like stave off the ketone production.
Yeah. So in a big picture sense, so it's almost exclusively in type 1. So you're absolutely correct. So the reason why in type 1 diabetics, it's when you have no insulin or like almost no insulin. So your cells are like, you have a lot of glucose in your bloodstream, but your cells themselves aren't seeing the glucose. So you end up releasing a ton of glucagon, right? Because insulin and glucagon are essentially odds, right? So if you have high insulin signaling, you have low glucagon signaling and vice versa. So you have low insulin signaling and high glucagon signaling. Okay, and so because there's so little insulin signaling, your glucagon goes crazy. So you make a lot of glucagon, and then your ketone production goes up a ton, right? And so it's that overproduction of ketone bodies that causes the acidosis. If I have just a little bit of insulin signaling, I'll still have glucagon, but it won't be such crazy levels that I overproduce sugar and overproduce ketone bodies. So you don't get the same picture. It is technically possible, but it is highly unlikely. It is almost exclusively in type 1 diabetics. I've seen many people with DKA. I don't think I've seen a single one that was a type 2 diabetic. Okay.
I have a question.
Yeah.
Yeah, for type 2 diabetes, right?
Yeah.
Since it's an insulin resistance type diabetes, shouldn't insulin level go up instead? Because there's no destruction of the pancreatic islet beta cell.
That's a great question. So your question is in type 2 diabetes, I thought that it was insulin resistant. So shouldn't you have a high insulin level? So that is technically true early on. So I don't want to go too much into the pathophysiology of type 2 diabetes, but in a very big picture sense, this is a step 1 question. They'll give you a picture and it'll be someone that's like in early type 2 diabetes, or they'll ask like, okay, this is someone that's in early type 2 diabetes. What is their insulin level most likely to be? And the question or the answers will be like low, normal, or high. In early type 2 diabetes, your insulin levels are actually high because you have resistance. So in order to overcome that resistance, you will actually go up, right? To overcome that resistance. Now, over time, you actually do lose your pancreas, and you can tie this into the fact that you have amyloid production in type 2 diabetes, because the amyloid production is going to slowly destroy your pancreatic beta cells, right? Because you're overproducing this insulin. So you get overproduction of amylin. So you get amyloid production in your pancreas. That's slowly going to destroy the islet cells. That slow destruction means that you are eventually not going to be able to overcome the insulin resistance. And that is going to cause that's why you eventually get type 2 diabetes. It's because you cannot produce enough insulin because your pancreas starts shutting down. That's why ultimately it's so bad when you have to start giving someone insulin or insulin secretagogues like sulfonylureas, is because you are now accelerating the process of the destruction of the pancreas. That's I think a little bit too much to go into right now for like biochemistry. So if that doesn't make sense, I'm happy to talk about it. Does. I'm happy to talk about that at a later time. But in general, insulin levels are high in the beginning of type 2 diabetes and low at the end, because you have overproduction of insulin and amylin causing amyloidosis. Amyloidosis is going to cause destruction of the pancreas. So you eventually won't be able to overcome insulin. That was something I didn't learn until I was in clerkships. It was an endocrinologist to explain that. Okay, so we talked about why this wouldn't happen in type 2 diabetes, because it's, again, you get glucagon elevation, but not to the same degree as if you have like minimal insulin signaling, like in type 1 diabetes.
Question, Alec.
Yeah.
There are some cases of type 2 also having this diabetic ketoacidosis, and you call them DKA-prone diabetics. They don't know why. Do you know why? I mean, what's the physiology?
So I would imagine that it would be, again, so if we're going to tie it into the overall pathophysiology of type 2 diabetes, my guess is that it would be in late type 2 diabetics.
Okay.
Because again, you have so much insulin resistance and so little insulin production that like you essentially are acting like a type 1 diabetic. It's like a type 1 diabetic plus, right? They not only do they have no ability to produce insulin, but they also have like a huge insulin resistance. So that'd be my guess.
Okay.
Like I would be shocked to find an early type 2 diabetic that was in DKA. Does that make sense? So it would be an insulin-dependent type 2 diabetic. Pathophysiologically, if I had to make sense of it, it would be an insulin-dependent type 2 diabetic whose pancreas was so far gone that they could mimic the low insulin, high glucagon state.
Okay, that makes sense.
Cool. Great question. Yeah. I love it. Because then we were able to tie it in together. Perfect. How is this different from ketosis? Because I remember, so again, I love biochemistry and I love eating. So like dieting, like learning about dieting just makes a lot of sense. Like the ketosis, right? So like in like any sort of like low carb diets, they're always talking about ketosis, right? I want to be in ketosis. And then people are like, no, ketosis is bad for you, like blah, blah, blah. But like ketoacidosis and ketosis, right? What's the difference? Who can, Patricia, what is the difference between ketosis and ketoacidosis?
Ketosis is a physiological pattern, and the ketoacidosis is a pathological pattern related to diabetes type 1. Ketosis is due to low carb diet. there is no excess of there is no cetonic bodies production.
Yeah, so basically ketoacidosis is just going too far, right? Ketoacidosis, we're overproducing the ketone bodies to the point of actually causing an acidosis. Ketosis is like, it's funny, like people that are like really into low carb diets, they get like, I don't know if it's like, they're basically like test strips, like ketone test strips, and they'll like test themselves to see if they're in ketosis. They even go so far as, I don't know, do you guys know, what is his name? He wrote the 4-Hour Workweek. Tim Ferriss. Anyways, he's really into this sort of dieting stuff. I was listening to his podcast recently. He brought in some guy, but he was like, apparently people like drink ketone bodies to like try to start. But like that doesn't make sense to me. They drink ketone bodies to try to like jumpstart the ketosis process. And certainly you can, like, your test strips will be positive for ketone bodies if you consume ketone bodies. That makes sense to me. Apparently they're just like awful tasting. They're like, it's like drinking like sludge and like rocket fuel at the same. It's just apparently awful. But I don't know that it actually would stimulate your body to produce ketones. That doesn't make sense to me. Anyways. Okay.
There's one other difference between just ketosis and diabetic ketoacidosis. In ketosis, you have the acetoacetate and the beta hydroxybutyrate being formed in equal quantities, whereas in diabetic ketoacidosis, the beta hydroxybutyrate predominates. So that's why when you test the patients, the normal ketone strips, test strips, will not work with them because the urinary ketone test strips have something called a nitroprusside, and that shows only acetoacetate in your urine, and it doesn't pick up the beta hydroxybutyrate as much. So you always, when you have the patient in diabetic ketoacidosis, you do measure both blood glucose and the beta hydroxybutyrate specifically in these patients.
I actually did not know that. That's cool. All right. Fatty acid synthesis. What's the substrate for fatty acid synthesis? Brendan.
Acetyl-CoA.
Absolutely. Lots of acetyl-CoAs. We talked about this last time. What's the breakdown product of fatty acid oxidation? Brendan.
Acetyl-CoA.
Absolutely. Right? How many carbons are in a fatty acid, Jolyn?
Many.
Yeah, exactly. Right. So why? Why is there many?
Because you need a lot of acetyl-CoA molecules.
Yeah, exactly. So if there's like 10 acetyl-CoAs, there's going to be like 20 carbons. Perfect. Okay. So what is the substrate for ketone body synthesis, MJ?
Acetyl-CoA.
Absolutely. 2 of them specifically. What is the breakdown product of ketone body oxidation, MJ?
Yeah, acetyl-CoA.
Acetyl-CoA, right? Does that make sense? So like, right, are you starting to see a pattern? Right, you put in a lot of acetyl-CoAs together and you make a fatty acid. You break down a fatty acid to get a lot of acetyl-CoAs. You put in 2 acetyl-CoAs and you get a ketone body. You break down a ketone body and it's 2 acetyl-CoAs, right? Like, at core, this is really all you need to know about these processes, generally speaking, for step 1 in life, right? I know that like you can sit there and try to memorize like all these pathways and stuff, but like really, this is it. This is what you got to understand. How many carbons are in a ketone body then, Omi?
4.
4, yeah, exactly. Yeah. 2 for every acetyl-CoA. Perfect. Okay, so acetyl-CoA. So what else is broken down into acetyl-CoA, Manali?
Beta hydroxybutyrate and the acetyl acid.
Yep. Definitely. But so those are ketone bodies. So we know ketone bodies are, we know fatty acids are. What else? What other macromolecules are broken down or can be broken down into acetyl-CoA?
Well, you can get glucose through glycolysis and then pyruvate dehydrogenase.
What else? How about proteins? Can a protein be broken down into acetyl-CoA?
Yeah, it can.
Can. Exactly. So in other words, you're telling me that all of the major macromolecules, protein, fat, and sugars, all of them can be made into acetyl-CoA? Interesting. Julie, so what kind of amino acids would be broken down into acetyl-CoA?
The kind that are ketogenic.
Ketogenic, exactly. And what is ketogenic?
That means that they can be breaking down to all the way up to acetyl-CoA and be produced and can produce ketone bodies.
Yeah, exactly, right? So this is why it's called ketogenic, right? Because you can make a ketone body. What do you use to make a ketone body? Acetyl-CoA, right? So I mean, this just makes sense, right? Like all these words like glucogenic, ketogenic, this should all make sense, right? Okay. So why does it make sense then that there are so many things that revolve around making or using acetyl-CoA? Okay, how about Patricia? So why does it make sense that so many things revolve around acetyl-CoA?
Because acetyl-CoA is a substrate to TCR cycle to acetyl-CoA and oxaloacetate to citrate. Basically, is a substrate to TCR cycle.
Yeah. Perfect. Yeah, it's used as a subject. It is the fuel for the TCA cycle. And Salia, so what's the TCA cycle used for?
I guess it's used to produce, would it be used to produce ATP and...
So everyone says that, but you don't really get that much
Yeah.
that much ATP directly from the TCA cycle. So, I mean, you ultimately do get ATP, but you don't really get it from the TCA cycle directly. So what are you actually producing with the TCA cycle?
I'm not quite sure then.
Did you watch the first lecture? Yeah, reducing equivalence. So what does that mean, Omi?
So they can be like once they're going to carry the electron basically like to the electron transport chain so that they can eventually end up in oxygen.
Yeah, exactly. Right. So you guys remember, so you have NADH and FADH2. So that's the main thing you're producing in the TCA cycle. Those are alternatively called reducing equivalents. Those are called electron carriers. There's a lot of different names for them, but basically they're just electron carriers. They carry electrons to the electron transport chain. And then with the electron transport chain, you harness that energy by creating a proton gradient. And then you use the proton gradient energy to turn ADP into ATP. If this does not make sense to you, there is a great lecture that is recorded on the website on the TCA cycle. I would highly recommend that you watch that. It's one of the solo lectures. So it's just me talking. It's pretty fast. Okay, so you get ATP production. So it makes sense, right? I mean, acetyl-CoA is just such a key molecule. And it makes sense, right? If you really take like a 10,000 foot view, a lot of this stuff makes sense. The reason why I really dislike the way that biochemistry is taught at most places is because like they'll go through all the different steps of all the different pathways, but you lose the forest through the trees. For step one, at least, and for life and like the practice of medicine, you don't really have to know like all of the individual nitty-gritty steps or the enzymes or things like that. You'll have to know like the major steps, certainly. You also know the clinically relevant ones, but you should be focusing on the big picture stuff. So that's why in all of these lectures, I'm trying not to show you the pathways because in the majority of cases, you don't actually need to know the pathways, funny as that sounds. Okay, ketogenesis. So we talked about this, the difference between ketosis and ketoacidosis. So why would ketone bodies produce an acidosis? We talked about. A ketone body is acidic, right? So acetoacetic acid is just acetoacetate. Beta-hydroxybutyric acid, beta-hydroxybutyrate, right? So I'm overproducing acids. It should make sense. I should have an acidosis. Okay. DKA and enzymes. So this is like a favorite question for biochemistry on step one. They're going to ask you, what is the activity level of enzyme X? And I cannot tell you how many times students will see that and their mind will just freeze. Their eyes will glaze over. They will start to like panic. The sympathetic tone goes up. So they're like, their heart rate goes up. They get a little sweaty because of M3 act, right? Like all of those things happen. So I want to talk to you about a way of thinking about these questions so that they become less scary. Okay, so the first thing to note is that when you're not trying to memorize a bunch of enzymes, right? You're not trying to memorize what happens to a bunch of enzymes in different processes, right? Because the number of scenarios are infinite where they could be like, oh, what does this enzyme do? What does this enzyme do? But really, they're not actually asking you about those specific enzymes. Instead, those enzymes are basically proxies for the process. When they say pyruvate kinase, they don't actually mean pyruvate kinase. They mean the process that pyruvate kinase is a part of. So, Ishwan, what is pyruvate kinase? What process is that a part of?
Glycolysis. It converts PEP to pyruvate.
Perfect. Exactly. Nice. Excellent. So when they say pyruvate kinase, they didn't really mean pyruvate kinase. They just mean glycolysis. Is glycolysis up or down? That's it. That's all they care about. How about Jeff? Pyruvate dehydrogenase. What process is pyruvate dehydrogenase a part of?
Glycolysis.
So again, they're not asking you about pyruvate dehydrogenase. They're just saying, is glycolysis up or down? It is essentially the exact same question as if they asked you for pyruvate kinase. How about hormone-sensitive lipase? Aparna. What process is that part of?
Hormone-sensitive lipase is uninhibited, so it's high.
No, but what process is it a part of?
Oh, sorry. It's a process of fatty acid synthesis. Is it? No, sorry, breakdown. It basically, triglycerides, it breaks it down into glycerol and...
So lipoic is part of lipoic.
DHAP.
Done. She's perfect. Sorry. Okay, so we talked about pyruvate kinase, pyruvate dehydrogenase, hormone-sensitive lipase. Okay, so glycogen phosphorylase. How about Brendan? What is glycogen phosphorylase a part of?
Glycogen breakdown.
Perfect. That was a little too easy. So how about acetyl-CoA carboxylase? What's that a part of, Brendan?
Fatty acid synthesis.
Good. Very good. What is the product of this enzyme?
Metabolic.
Very good. Well done. Nice. Did you know that or did you watch the videos?
I've been studying.
Well done. Very clearly. That's good. A lot of people do not know that. Pyruvate carboxylase. What is this a part of, Julie?
Gluconeogenesis.
Gluconeogenesis. Exactly. Perfect. Okay. So would the activity of the following enzymes be decreased? Because again, this is like one of the most popular questions. Is the activity of enzyme X like up or down? Or like, are these enzymes, right? They'll give you like a bunch of like up or down arrows. You guys have seen this, right? When you're doing QBank questions, this is so common because they're not gonna, like the easy question would be like, oh, okay, well, you know, what is this process up or down? Because honestly, even if you don't study biochemistry or if you don't know these processes intimately, you can usually still answer those questions. To be honest, it's not that much harder once you figure out that the enzymes are just stand-ins for the processes themselves, okay? So pyruvate kinase. So would the activity of this enzyme be up or down in DKA, MJ?
Going to be down.
Yeah. Okay,
Actually, at first I cannot figure it out. And then I just think because it's diabetic patient, they cannot use glucose. So all the glucolysis, the activity should be decreases.
Yeah, perfect. Yeah, exactly. Pyruvate dehydrogenase, Minali. Would this activity be increased or decreased?
It'd be decreased.
Perfect. Yeah, same reason, right? Hormone-sensitive lipase, Daniel. Would this be up or down?
It's increased because it's disinhibited.
Perfect. Good. So, I mean, it's even better if you actually can think about the mechanism. So that is good. But even if you just think like, okay, lipolysis, am I going to break it down? Am I going to want to break down fat if my body cannot use sugar? Yeah, totally. That makes a lot of sense, right?
How much can the body's metabolic compensation by increasing either glucagon or epinephrine account reverse these?
I'm not sure I understand your question.
Like in DKA, will these always be like decreased until the underlying DKA is treated, or how much can the body, or decreased or increased, or how much can the body compensate to reverse the changed activity?
You talk like pyruvate kinase and pyruvate dehydrogenase.
Yeah,
those
exactly. Yeah.
Oh, I see. That's a good question. I don't know that I know the answer to that. How much can the body compensate? So you're saying like you're turning down glycol. I mean, because you don't really have sugar to use. It's not like your body is compensating to try to conserve energy, if that makes sense.
Mm-hmm.
I wouldn't think about it that way. If anything, your body is just like revving into overdrive. Because like think about it, right? Like you're breaking down fat to try to furnish the material to make ketone bodies. Because your body is like starving, can't use glucose. It thinks it's starving, so you can't use glucose. So you're like, but I don't know that I would think about it as like compensation, if that makes sense.
Okay.
This is actually like the opposite of compensation. It's like the body's normal mechanisms, but like it is maladaptive.
I guess until you treat the diabetic ketoacidosis per se, these enzymes will not revert to normal.
Correct. Is that what you were asking? Because that's a much
basically.
Okay. Okay. That's a much better answer to your question than what I said. Good. Okay. So glycogen phosphorylase. Should that be Minali? Or how about Santosh? So glycogen phosphorylase, is that going to be up or down?
Actually, I have a question. I don't understand what the activity of the enzymes means per se. Is that something like
oh, I see. So will the number of reactions per second be increased or decreased relative to normal?
Okay, so it'd be increased then.
Okay. Yeah. Why does that make sense?
You're going to need to produce more glycogen? No, break down more glycogen.
Well, why would I try to be breaking down more glycogen?
For energy. Energy, you want to make more glucose, right?
Yeah, exactly. I mean, your body is like starving of glucose. Even though your bloodstream is swimming in glucose, your glucose may be like, so normal glucose is like what, 100-ish, depending, right? Mm-hmm. So your glucose might be like 900, 1,000, right? Because your body cannot use the glucose in your bloodstream. So yeah, so your body is going to churn out a ton of glucose. Acetyl-CoA carboxylase, Salia, is that going to be up or down?
It'll be decreased.
It'll be decreased. Okay. Why? Why does that make sense?
You are trying to, sorry, let me just get to, the glycogen phosphorylase. It'll be decreased because you're trying to make more glucose?
No, acetyl-CoA carboxylase.
Oh, sorry, my bad.
So the explanation is not in the PowerPoint.
No, I know. I was trying to think through why the acetyl-CoA carboxylase would be decreased.
So the key is to think about the process, right? So if whenever you're struggling, because this is going to happen a lot, instead of thinking about the enzyme, which you probably don't know a ton about this enzyme.
Yeah,
right?
Exactly.
But instead, you want to think, okay, what process does this represent? So what process does acetyl-CoA carboxylase represent?
Fatty acid synthesis.
Fatty acid synthesis. Okay, so then you got to think, okay, well, in DKA, when my body is starving, trying to break down fat and make ketone bodies and break down glycogen and turn 3 carbon structures and above into glucose, am I going to want to make
so
fat?
then your body wouldn't, no, exactly. So your body wouldn't be making any more fat.
Perfect. Exactly. Does that make sense? So that's what, again, you guys may think I'm silly to like spend this much time talking about like, oh, will this enzyme be up, increased or decreased? But again, this is a really good example, right? Because when you're faced with it, you're going to be like, oh my God, I know nothing about this enzyme. But if you take a step back and you're like, wait a minute, I know what's going on though in the body, right? I know what processes should be up or down. You're like, okay, well, in DKA, am I going to want to make fatty acids? No. So then it's very obvious what the answer should be. Does that make sense, guys?
Yeah.
I bring this up because this is like the most common problem that I see in biochemistry. A lot of you guys haven't like gotten to, some of you guys during your dedicated study period, some of you guys have not done a ton of biochem questions. You'll have to trust me on this. This is a really, really, really common issue. Pyruvate carboxylase, OMI, what do you think? Increase or decrease, and why?
Because it's for gluconeogenesis, it'll be increased because I guess the body, like the cells, think they're glucose deficient.
Yeah, exactly. So they're going to try and reduce it. Perfect. Exactly.
Hey, Alec, I have a question. So we are making more glucose like through glycolysis and gluconeogenesis, but if we're not using glycolysis to produce ATP from that, like why would you want to make more glucose? Like why is it just using reserve fat?
Exactly. It's because, so the problem is that, so that is a great question, right? So your body is not doing something intelligent is sort of the short answer. Your question is like, why wouldn't your body adapt in other ways?
Right. Yeah.
So, but you understand why you can't do glycolysis, right? I guess I should be specific. Really, I should be talking about glycolysis in the liver because technically I think that's probably the area we should focus on. You know, because that's the thing that's going to be insulin dependent. Right, so glycolysis in the liver is going to be down because you have no insulin. Even though your blood sugar, so the glucose outside of the cells is really high. The glucose inside of the cells is going to be pretty low because you don't have any insulin.
Does insulin act on glucokinase in the liver to take up the glucose? Is that why you need insulin to be around for glycolysis to occur?
So you should have, so your liver will actually have glucose in it. The issue is that because you don't have insulin, some of the enzymes themselves are insulin dependent. Does that make sense?
I see. Yeah, makes sense.
Because you have GLUT. Oh God, I always forget. I think it's GLUT. Well, you guys tell me.
GLUT4.
Yeah. So, well, what is GLUT for? What do you mean?
That's the insulin dependent one. It's on fat and muscle though.
Right. So it's not GLUT4. I think it's GLUT2. Where it has a relatively high, essentially a high Vmax, if you want to think about it in terms of like kinetics. So in other words, it has a relatively high Km and a high Vmax.
Yes, that's GLUT2.
Yeah. So
and that's on liver and beta cells of pancreas.
You will still have glucose in the cell, in like your hepatocytes and in your pancreas. The problem is that, well, in your pancreas, it doesn't matter because you can't release insulin in type 1 diabetes. So that doesn't matter. And in your liver...
Alec, does it have to do with K2 level?
What level?
PFK2, fractalkinase 2 level?
Yes. Yeah, that is part of it. Because insulin... Okay, so tell me how that would affect. How would that be affected?
If insulin is up, your CAMP will go down and PKA will go down, and your phosphofractalkinase 2 will go up. So you will be making more fructose 2,6-phosphate, and it will upregulate your PFK1 and glycolysis pathway.
You're saying in the case of high insulin?
Yeah, high insulin.
Right.
So
in this
if
case,
there's
it's
not enough insulin, it will be the other way around. Yeah.
Perfect. Yeah, exactly. Does that make sense?
Yeah.
Yeah. Alec, I have a question.
Sure.
Okay, so in the pancreas, usually when insulin released from the pancreas, it's caused by the glucose getting to the insulin. And there is no insulin resistance in the pancreas, or it should have, because it's in the first stage of that. What about the glucagon? How could the glucagon be released? Because it cannot sense any glucose into the pancreas, so that's why the glucagon released into the blood, right?
Correct.
So
Well,
if there
to be honest, I actually don't know the exact mechanism of how glucagon is released. I'll be very honest with you.
Okay.
Does anyone know?
All I know is in type 1 diabetes, the beta islet cells are, damaged because of auto antibodies.
Yeah, I still don't know. I still don't know. Like, so the mechanism for insulin release is well worked out.
Yeah,
I don't know.
right,
I
no,
don't
the
know the
alpha
exact
cells-
mechanism.
No, I was coming to it. That alpha cells are retained. I mean, they're normal. So they still continue to, release glucagon. And as someone just said, it doesn't sense glucose. So it thinks there's no insulin. So glucagon keeps getting secreted.
But is that true? Is that actually the mechanism for how glucagon is released?
That's what I read. But
I,
we
I,
could look it
I
up.
read from up to date. I read from up to date that glucagon is being inhibited by insulin. So if there's no insulin, then glucagon will be released.
So that was my understanding that they
That
are
makes sense.
antagonistic. But again, I don't know I assume it's a disinhibition mechanism, but I don't actually know. This is just like a general thing. I just know that in general, when you have low insulin, you have high glucagon and vice versa. So I don't know, but I'll have to look that up because it's actually very interesting. I don't know. I don't know what the exact mechanism is.
Yeah, so that's why if there is no insulin in the blood, so more glucagon will be released into the blood. That's why the body cannot use the glucose and also increases the glycogenolysis and also the gluconeogenesis. So that's why I want to explain into the glucagon into it.
I see. I mean, you can also just think about it as just like the lack of insulin will lead to all these things too. Because usually when insulin is acting, like usually insulin and glucagon have antagonistic actions at all of these things. I don't think you have to invoke glucagon for some of them. Some of them you do. Some of them, obviously the overproduction of ketone bodies.
Depend on the glucagon.
Gluconeogenesis, I think you would too. Okay, let us move forward. I will look up the mechanism of glucagon release, or if someone wants to look it up, we'll see if it is just an antagonistic relationship with insulin. Okay, so what is the sodium level of someone in DKA, Brendan?
Low.
Okay, why?
Would you get like osmotic diuresis from the increased glucose?
Yeah, but that wouldn't. But how does that lead to low sodium? I mean, what you're saying is true, but it's sort of like true and unrelated. I'm not sure that is. I'm not sure how that relates.
Just like their
You're
solvent
saying like a hypovolemic hyponatremia, hypertonic hyponatremia.
Sorry, say that again.
So are you invoking a hyponatremic a hypotonic hyponatremia? He's saying hypovolemia, increase in ADH production, over reabsorption of free water, dilution of everything in your blood, including sodium. That's what you're saying?
Yeah, that could contribute to it. That makes sense.
But it's not true. It's not true. You can't let people put words in your mouth. Sure. But I mean, but that's the only way that you can tie it with an osmotic diuresis. So the mechanism is not osmotic diuresis. That's my point.
Due to the hyperglycemia?
Oh, okay. Maybe. Can you tell me how that could lead to hyponatremia?
I don't know. I'm just guessing. I'm thinking because if you're already hypertonic, the body wants to try to make you isotonic. So it tries to get rid of sodium, which is the only way that like aldosterone can work, right? In ANP.
Very good. I'm actually really impressed. So there are two ways to explain it. One is exactly the way that you just described it, right? Which is that in general, the biggest contributor to your osmolarity in a normal person is sodium, your serum osmolarity. The biggest contributor is sodium, right? Now, if your glucose is now like 10 times normal, that may no longer be true. And so you may be hypertonic even though you're hyponatremic. So one way to think about this is exactly as you were saying. You decrease the amount of sodium, your kidneys are sort of decreasing the amount of sodium to keep your tonicity the same. Because really it's tonicity that you care about. It's not really sodium per se, it's really the tonicity that you care about. If your tonicity, meaning the amount of stuff dissolved in your blood, if that's high, it doesn't matter if it's sodium or sugar, your body's going to try to compensate. The other way to think about this is that your tonicity is high, water is going to follow solute. So if my tonicity in my serum is higher than my tonicity inside my cells, where is water going to move? Is it going to move into my serum or into the cells?
To the serum?
Into the serum, yeah. So I'm going to have water that's going to move from the inside of my cells to the outside of the cells. So that's going to essentially dilute, that's going to cause the concentration of everything else in my blood to decrease. So there's sort of two ways, I think both of these mechanisms contribute, right? So you can think about it sort of both ways.
I have a quick question.
Yeah.
Wouldn't that wouldn't give you an osmotic diuresis at all? Because isn't that going to make
will give you an osmotic, but not that is not related to the hyponatremia. You do get an osmotic diuresis, but we'll talk about that later.
Okay.
For potassium, right? I know that it's going. The potassium will be excreted out of the body, but why is it not true for sodium?
I'm sure you still do lose some sodium, but that is still not the mechanism. I see what you're saying, because you're losing sodium. You're losing sodium as well. That is true. But again, that doesn't cause an increase. That wouldn't cause a decrease in because you lose sodium proportional to the amount that's in your serum, right? You're not going to lose extra sodium. So your concentration shouldn't go down because of an osmotic diuresis. Does that make sense?
Yeah.
Right. If I lose 140 milliequivalents of sodium per deciliter, it's not going to decrease the concentration of sodium. That in and of itself will not cause a decrease in the concentration of my serum. So what you guys are saying, what both Brendan and Eastman are saying is correct. You will still lose sodium, but that does not explain why you have a hyponatremia. That's what I'm pushing back on you guys with. There's still not a clear mechanism for how that could lead to a delusional hyponatremia. This is what you guys should think of for why you get a delusional hyponatremia. Okay, so how do you correct the delusional hyponatremia in DKA? Like, how do you get it to get better? Jolyn.
How do you correct the hyponatremia? It could restrict fluid intake.
This is great. This is like that's like the hospital answer, but that's okay. But again, you have to think about the mechanism, right? And this is true in general of hyponatremia. It's funny. I had a patient recently in the ICU that their sodium was like, it was like 120 or something. It was like really low. And like we were checking sodiums every 4 hours on this patient. And eventually I was like, wait a minute, this doesn't make any sense because the mechanism of the hyponatremia is not a hypotonic hyponatremia. So it's not going to correct quickly. And even if it did, that wouldn't cause central pontine myelinosis. And it's funny because I actually like calculated the serum osmosis. You could tell like the fellow was like, what the hell? Like how the heck does this kid what is he doing calculating the serum osmosis? It was pretty, but so my point though with hyponatremia is it's not a simple thing of like, when I first started, I was like, oh, low sodium, you have to like be worried about correcting it and like, reduce free water intake. You have to correct it slowly. Otherwise you can get like brain problems and all that stuff. But what you realize as you do this more, or if you read about it early on, is that it totally depends on the mechanism. Not all hyponatremia is the same. A sodium of 120 does not always mean the same thing.
I see.
So that is not the way to correct it in this case. So walk me through. So what's the mechanism of the hyponatremia in DK?
It's hyperglycemia induced.
Causing what?
Causing the body to lose its sodium, or water could be shifting from the cells into the serum.
Good. Okay. Why does water shift from the cells to the serum?
Because the serum is hypertonic.
Perfect. Yeah. Exactly. So if the mechanism is because you have high glucose and high osmolarity and free water is shifting, so how would you correct it in DK?
Would you give an isotonic solution to balance it out?
Or you could give insulin.
You just give insulin. You just correct the underlying problem.
To get the body to use the glucose in the serum.
Yeah, exactly. You just treat it. You just treat the DKA, right? So you give insulin. You lose this extra, you normalize the serum sugar, and then you lose that osmotic gradient so that you're not pulling out the water from the inside of the cells and diluting everything else. That and your osmolarity is going to fall. And so your kidneys will not have you be so like diluted out. You can look at it both ways.
I see.
But you're not treating it per se. But if someone came in and like let's say that they had like SIDH, that is very different. How you correct that is very different. So someone comes in with DK with a sodium of 120, you treat them with insulin. Someone comes in with SIDH and a sodium of 120, you don't give them insulin, right? Like again, you have to think about the mechanism. And that's I think one of the hardest things that I have learned as a resident is like you treat these things very differently depending on the underlying cause. And depending on the underlying serum osmolarity.
I see.
Right.
So is that the case in hyponatremia? You always treat the underlying cause?
Yeah. In a very big picture sense, that is true. And the only one that you really worry about, what kind of hyponatremia do you really worry about in terms of correcting it too quickly?
Central pontine.
Well, yeah, that's the consequence that you worry about. But what underlying like pathophysiology do you really worry about? So that's a bad question. The thing that you worry about is when you're hypotonic.
Yeah.
If you're hypotonic and hyponatremic, that's the one that you really worry about. Because we'll talk about this later. But that's one that you really worry about. In any case where you're like hypertonic, it doesn't really matter. It'll correct, even if you corrected like in 2 hours, it still wouldn't matter, right? Because it's the tonicity shifts that you really worry about. That's what you really care about. So that was why there was a guy that came in, he had appendicitis, had nausea and vomiting for a really long time. So it was like grossly hypovolemic, but had like really, really, really bad kidney failure because his kidneys were already bad to do as a diabetic. So like close to end-stage renal disease, came in really dehydrated. So had a profound ischemic ATN when he came in. So his BUN was like almost 100 when he came in. And so his sodium was like 120. It was really, really low, but it was because it was the same mechanism. His osmolarity was actually high. And if you calculated the serum osmos, it was actually high. And that was what I did on run. So it was like serum osmos are high. It doesn't really matter. We don't have to worry about his hyponatremia. It is not a hypovolemic, hypotonic hyponatremia. There's like, we can measure his sodium every other day and it doesn't matter, right? We're not going to give him central pontine myelinosis. And they were like, oh, that's great. Now he doesn't have to be in the ICU. But I mean, these things matter. These things, your understanding of these things actually does matter in your ability to take care of these patients. Okay, so we said that we do not have to worry about correcting it too quickly, right? So Can someone explain to me again, because again, this is really complicated. So Daniel, do you want to give it a shot? Why do we not worry about correcting it too quickly? Because honestly, at your stage, I could not have explained this. I didn't even understand this was a thing. I just thought all hyponatremia was the same.
Basically, it's a falsely decreased sodium level. It's not a hypotonic hyponatremia. It's just the high extracellular glucose level is the underlying cause of it.
But I was always told that sodium has to be corrected at 1 milliequivalent per deciliter per hour, always. So why do I shouldn't worry about it in this case?
It should be corrected, but not via fluids. It should be corrected via treatment of the underlying decay.
Okay.
And that will correct it. That will actually.
But what I don't understand, and what I couldn't have explained at your stage, was why do I not worry about it correcting too quickly? What's this whole thing about tonicity? Why do I really care about tonicity? So in other words, like, what's the mechanism of getting central ponchian myelinosis? But Daniel, or unless you want to pass it off.
Because if you mechanism that is that you could, if you give fluids too quickly, your extracellular osmolarity is which leads to a shift from intracellular to extracellular water.
Exactly.
Shrinking the cells. In this case, the osmolarity difference between the inside and outside is not great. There won't be a shift.
In other words, you're not changing the osmolarity of the outside relative to the inside very quickly. You could, yeah, exactly. We'll talk about this more later, but that I want to plant that seed right now. You will talk about this also. Okay, so in hypotonic hyponatremia, right? So like SIDH, like the classic example. If your sodium were to rise really quickly, would it change the extracellular osmolarity, Julie?
Yes, it will.
It would.
So it's gonna rise.
Perfect. Yeah. So because again, in most people, sodium is the main thing behind your osmolarity, right? If you like in that serum like osmolarity calculator that I used, sodium is like the biggest part of it by far. So if I'm hyponatremic and hypotonic, then if my sodium rises quickly, it would change my extracellular osmolarity. So would this lead to a large free water shift, Julie?
Absolutely, yes.
Yeah.
And then you have the chance of central pontine myelination.
Yeah, myelinolysis. God, it's like such a hard word to say. So if my osmolarity increases in my serum, then I'm going to have a lot of water that's going to leave the inside and go to the outside. But it's really the osmolarity that we care about. That's why we're like looking at the sodium. There's nothing special. So when I was at your guys' stage, I thought that there was something somehow special about sodium that I just didn't understand. I was like, oh man, if sodium changes too quickly, somehow it's like magically going to cause central pontine myelinosis. That is not true. The reason why it's bad is because if I have chronic hypotonic hyponatremia, then the osmo, so like let's say that my serum osmolarity are normally around 295, 300, right? But let's say that it's 270, right, or 260, right? My sodium is really, really low. It's 260, let's say. The inside of my cells are also going to be 260, right? And so the problem is, so inside of my cells, osms are 260. Outside of my cells, milliosms 260. Now, if I change my serum osms, right? So if I increase my serum sodium concentration, I'm going to change my my osmolarity. So what if now inside is 260, outside, so my serum is like 300? That is bad. That is going to cause central pontine myelinosis potentially because you have water that's going to shift from the inside to the outside. So the inside of the cells are going to get really dehydrated. The osmolarity is going to change very quickly. That can cause neurologic problems. Let's take the opposite example. So Omi.
I'm sorry. I have a question.
Yeah.
So what is the physiologic cause? What caused the myelination destruction?
I knew that someone would ask. I don't know. I looked it up. I don't know. I tried to figure it out, but I don't. If someone knows the answer, please let me know. Because I have always wondered that. Like, why would a rapid change in the intracellular osmolarity or like water shifting out, why would that cause demyelination specifically? I don't know.
I looked it up a bit. So it's kind of like the brain has this adaptive mechanism to prevent change in tonicity in your body. So whenever there's a change in tonicity, the brain will try to protect itself by releasing the intracellular or whatever that's inside the cell, as in like your potassium will be out, and basically to prevent it from getting cerebral edema. And this adaptation will go on, will start from beginning and it will peak at a few days after the change in the tonicity of the serum level. What I get is if if the change in tonicity is acute, then correcting it rapidly will not cause sometimes something myelinosis. However, if it happens after a few days.
But I still don't.
It's that when you correct it too quickly, then it's going to release cytokine.
Yeah, but whenever someone says cytokines, it means we don't know. Seriously, I mean, right? Like, if anyone ever tells you, oh, it's because the cytokine storm, means they don't know the answer. Because I mean, cytokines could mean anything, right?
Yeah.
Have you ever gotten that answer? Like, oh, what is the mechanism for why, like, you get, God, I don't know, ARDS? Like, oh, cytokine storm. It's just because they don't know the answer, right? I mean, it's true. I mean, what they're saying is not false. It's hard to disprove that, but that doesn't really explain the mechanism. That cytokine storm is never a mechanism. I'm sorry.
Every autoimmune disease lecture.
Yeah.
Sorry, guys.
Yeah, exactly. No, it's okay. I have the same issue. But again, like, you ran into the same sort of like bad explanations that I ran into. It is true. What Eastman is saying is true. If it's an acute change down, like, you can correct it fine. And again, it makes sense, right? Because the inside of the cells haven't had a chance to adapt to, like, you know, they haven't decreased the amount of stuff that's dissolved on the inside of the cells, and, you know, stuff that can't cross the cell membrane to, you know, adapt to the low osmolarity. The one that you worry about is chronic hypotonic hyponatremia. And God, to be honest, at your stage, I didn't even understand what the significance of a hypotonic hyponatremia versus like a hypertonic hyponatremia. I did not understand the difference. I mean, if you'd asked me, I would have been able to explain it, but I wouldn't have understood the significance. Okay, so in pseudohyponatremia, so if the sodium would rise quickly, would it change the extracellular osmolarity, Santos?
Pseudo, probably not.
Probably not. I need you to put your nickel down.
What?
I need you to say, like, definitively, yes or no.
Yeah, no, I don't think it's going to change.
Perfect. Good. Yeah, it should not. Because again, the extracellular osmolarity is already high, right? So if your sodium rises because something else falls, it's not going to change the osmolarity. Would this lead to a rapid change in extracellular osmolarity relative to the intracellular osmolarity? How about Jeff? Would this lead to a rapid change in the extracellular osmolarity relative to the intracellular osmolarity?
I would say no.
I want you to be more confident. You have to take a stand in general for all of these things. I want you guys to take a stand. If you're wrong, fine, but just be wrong boldly.
Okay. No.
That's enough. Okay. Good. Why?
Let me think about it. I'm not too sure. It was a guess.
Oh, it's a confident guess, and you were correct. Can someone help?
Is it having to do with you mentioned earlier, it all based on like the tonicity. So in the pseudohyponatremia, it's not going to be as big as a shift, like as in the, like,
What do you
when
mean
gave the
shift?
example.
You have to be more specific.
Like when you gave the example with 200 inside the cell and 300 outside the cell, you said that would cause a larger shift in the water.
Perfect. Yeah.
Heating. But in this case, we're not going to see that because we won't have such a big difference between.
Yeah, there's not going to be a difference. So it would basically be like, because your sodium going up doesn't increase your osmolarity. So you're not going to really change the serum osmolarity relative with the intracellular osmolarity. So instead of it being like, you know, they both are 200 extracellular, intracellular, and now it's 300 and 200, right? Now it's like, I don't know, 320. They're both intracellular is 320, extracellular is 320.
Alec, can you just write down the numbers in the
Sure.
PowerPoints? I just follow.
Yeah, great suggestion. So in the case of like hypotonic hyponatremia, so before correcting, maybe it would be like intracellular sodium would be maybe like 260 milliosms, and the extracellular sodium would be like 260 osms. And then after correcting, it would be extracellular might be like 300, and the intracellular would be 260. So this difference is what you worry about. This is the difference that's going to give you central function myelonasis, right? Because now free water is going to shift from the inside of your cell to the outside. In the case of a pseudohyponatremia, your serum osms and your intracellular osms are actually going to be high, right? So I think when I actually measured it, because I was like, I just want to make sure that I'm correct. I don't want to like give this guy brain damage. So I actually measured the serum osms. I think they were like 320 or 315 or something like that. So before correcting, the extracellular, this shouldn't say sodium. This should say osm. Sorry. Okay, so the osms don't change, right? So the osms, the osmolarity is going to be the same, right, before you correct it. And then after you correct it, there's going to be a difference in the osmolarity, intracellular and extracellular, for hypotonic hyponatremia. Does that make sense? For pseudohyponatremia, the intracellular osms are going to be high, right? So it'll be 320, maybe 320 and 320. After you correct it, the intracellular osms, the osmolarity, is going to be the same. It'll be about 320. And the extracellular is going to be about 320. So there's no difference between these.
Alec, is pseudohyponatremia a kind of like hypertonic hyponatremia?
Yes. I don't know that they are always the same thing, but yeah, essentially. Yeah, I think you can use those interchangeably. I cannot think of a situation in which that wouldn't be true. There may be, but yeah, they're essentially the same thing. Cool?
Thank you.
Does this make sense? MJ, does this make more sense now?
Yes. Perfect. Thank you.
Yeah. Okay. let's talk a little bit more about electrolytes. So what's the classic triad seen in newly diagnosed type 1 diabetics? Patricia.
Polyphagia, polyphagia.
Yep. Two other things.
Sorry, I forget the
Can someone help?
triad.
Well, just think about the
It's
pathophysiology.
easy, but I forget. Sorry. Dysphagia, is polyphagia, polydipsia.
Dipsia. And you're polydipsic because you are?
Because polyphagia because you have intracellular starvation, polydipsia because you have a lot of water inside the cell, polyuria because
Polyuria.
you have osmotic diuresis.
Perfect. Yeah, exactly. Yeah. So you get osmotic diuresis. So you're hypovolemic. That's why you're drinking a lot. It's because you're hypovolemic. You're really thirsty because you're peeing out a ton, right? And then you get the cell starvation that causes polyphagia. Okay. What's the total body potassium of someone in DKA?
Normal or high?
Actually, it's neither.
Low.
It's low. Okay. So why is it low? Why is the total body potassium low?
Because it's been as like a buffer almost, because we're saying DKA is the ketoacidosis. So I guess you could use although.
It's not a buffer. I don't know the buffer is the right term. Brendan, what do you think?
Is it osmotic diuresis now?
Osmotic diuresis, it is. Perfect. Okay, so what's the mechanism? And so what does that mean?
You have a lot of glucose, which increases or decreases the amount of, I know that it's because of solvent drag, because your glucose is kind of pulling solutes along with it as it's retaining water in the kidney.
Good. Yeah. And this is honestly a mechanism that never really made sense to me. Like solvent drag is it's a really cool term. So in other words, your proximal tubules, your proximal tubules can absorb maybe up to 200-ish, right? It's sort of where it tops out in terms of amount of glucose that it can reabsorb. If you get above that, all that glucose cannot be reabsorbed. So you're just going to lose it in your urine, right? And because water follows solute, you're going to end up losing a lot of water. Somehow, magically, when you have one solute that is lost, it's going to pull other solutes with it. That is something that honestly never quite made sense to me. I'm sure there's a chemical explanation for this. I just don't understand it. But it is a real thing. So you're going to lose potassium along with it because of this magic thing called solvent drag. Again, I don't fully understand this. And I was a chemistry major, so someone can explain that to me sometime, however you want it. So what's the serum sodium of someone in DKA Aparna?
Oh, that just threw me off. I know it's low.
Nope.
Normal or
It
high?
can be, but classically it's actually going to be what?
It's actually normal. It's just that the water content in the extracellular compartment is more. So
true?
It appears like because
So it's
the
actually
glucose
normal.
is out in
Oftentimes it's
extracellular
high. So classically, when you see it for step 1, it's going to be high. And you're going to be like, why the heck is it high? So can you...
The sodium follows glucose
Because sodium follows glucose.
out into the extracellular compartment.
We're talking about potassium.
Oh, sorry. I thought you asked about sodium now.
Serum potassium. So if I said sodium, I apologize.
Yeah, sorry. Yeah, that's what I was thinking. Potassium. What's the serum potassium in someone with DK? Initially it's high because of that buffering, when the hydrogen ions go in.
That is interesting. That is actually not true.
That is only initially.
No, it's actually not true. It's actually not. It is not because of the acidosis. I used to think that was true, and that is classically what's described. But that has been described in multiple papers since as not being true.
Okay, then eventually it is low at the serum because you're losing it in
No,
the
but it's high. No, it is high. It is high. Oftentimes it is high. So the question is why? But it's not. So I'm going to tell you a little story about a student because it's funny because I told him, I was like, the mechanism is because hydrogen and potassium are they can be used sort of to buffer the serum. And he was like, actually, that is not true. I was like, what? I'm pretty sure that's true. He's like, no, our professor told us anyways, the reason I tell you this is not to, it is in part to point out that I too am fallible and have learned incorrect mechanisms in the past and have had to relearn them when I found out that what I'd learned was incorrect. The other reason why I point this out though, is because this student, what do you think he got in this? It's 250 something. I forget exactly. It was 250s, somewhere in the 250s. So the reason I point this out is because that is exactly the kind of student that does well in step 1. Okay. So this is going to be my a little divergence that I just want to point out, just because I want you guys to really understand what it means to do well on this test. I cannot tell you how many people email me every single day, and I get a lot of emails, and I know it's going to increase now as we get closer to May and June and July, because this is just how it happens every year. I get emails every single day from people being like, I want a 250 or I want a 260. And these are the resources that I use. To be honest, every single time, the resources are almost always the same. I use Pathoma, I use Rhubarb, I use Crustave, I like blah, 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 right? Like, it's always like the same resources. The problem is that like everyone is using the exact same resources. So like, even if you knew that perfectly, I would argue, I've never seen someone who only knew those resources that scored a 250. Never. And I've been doing this for a long time. Never have I found someone where that was how they scored. In every single case that I have seen of someone scoring above a 250, honestly, and usually even scoring above 240s, although I think those resources are probably enough to get 240s. But like 250, definitely 250, right? You have to know more than is in those board review books. Let me repeat that. There is no way that by just using the like UFAP, whatever, I don't even know, UFAP, right? That's what all the kids are saying these days, right? There's no way that you're going to get a 250. No way. I would bet large amounts of money that you will not be able to do it. Even if you're in this group and you used every single resource available in the group, and I just don't think it's possible. Because you have to be able to have thought about this at a deeper level than just like the cursory stuff that you're going to get. Because even as good as Pathoma is, he can still only teach you so much in his lecture videos. As good of a resource as first aid is, even if you knew everything in first aid, it's still not enough. You have to understand the body to a deeper extent than just what you get in these like board review stuff. So the reason I point this out, that this student, like that this was the student that pointed out that this was the incorrect mechanism, is because he had thought about it. He was like making sense of it. Even the stuff that didn't show up, do you think that was in like first aid? No. Was that in Pathoma? No. Was that in UWorld? No. Will that show up on his test? Probably not. But that is exactly the kind of mentality that I think you need in order to be the kind of person that's going to score 250, 260. I just want to tell you guys, like, it is really important that you guys, especially if you are not yet in your dedicated study period, it is really important that you are learning the stuff that they're teaching you in class. Because it is not okay to just sit there and be like, oh, well, this isn't in first aid, I'm just going to ignore this. You want to make sense of all this stuff. As bad as I thought some of the lectures were at Stanford, they still taught some pretty useful stuff that I didn't appreciate until much later. Okay, so do not just do this stuff, especially if you're not in your dedicated study period. You can still go back and make sense of this stuff. That's not in the board review books. Okay, someone was going to say what the mechanism was. I don't need to scare you guys. Yeah, go for it.
Okay, so because we have hyperglycemia, we have water that's coming in. And so
you got to be specific, because you got to be specific of what do you mean in.
So it's coming intracellularly to extracellularly.
Perfect. Mm-hmm.
And then so we have a gradient between the potassium that's in the cell versus out of the cell. We have more potassium that's inside the cell.
Oh, now what do you mean there's more potassium inside the cell than outside of the cell? What does that mean? Because really the number of potassium molecules should not change.
I guess it's more of like the gradient that's created.
Okay, so why? Why would the gradient change?
Because of the water response that's happening due to the hyperglycemia?
No, there's a more basic, simple explanation for this. Because you're saying like it's like the perfect med student answer. It's like some pretty fancy sounding terms, but not a clear mechanism. Think about it this way. Okay, you want to go? Want to try?
Oh, can I try? Try.
Or Aparna spoke up first.
I'll wait. Oh, I'll wait. Let her go. It's okay. I don't want to make a fool of myself.
Yeah, it's not a fool. No, this is great. You guys,
I'm
this is like
thinking.
the way to do it. Go ahead.
Okay, so in Ka, your glycolysis is not, you cannot occur glycolysis, so there will be a decrease in ATP level, and your sodium potassium pump cannot function. Your potassium will constantly be outside of the cell instead of being pumped in of the cell.
So that is part of it. Yeah, sort of it. Part of it is the sodium. So that is part of it. So part of it is the lack of insulin. So you have lack of activity of the sodium potassium ATPase. Presumably, if your cells don't have as much ATP, so that's a great. I love that explanation. That is part of it. That is not the explanation I was thinking of, but that is part.
Oh, sorry. I didn't read about it. I was just thinking about it. So
no, it's great. No. I think that's great. So the sodium potassium, like whenever you can think about the sodium potassium ATPase, I think that's fantastic. So that is part of it. What else? God, who was
the only thing I can think of is because of hyperosmotic state, the cells shrink, and so potassium gets pushed out with the water.
So that's part of it. So there is an aspect of solvent drag, right? That magical solvent drag where somehow potassium is going to follow water that goes out in a way that I don't really understand. That hand wavy explanation is still there. Apparently it's true. So the other thing is that so the classic explanation is the metabolic acidosis one. That is not true, which is interesting. I didn't know that is true. It's only true for inorganic acidoses, of which there aren't that many. If you added like hydrogen, like hydrochloric acid to someone's blood, that could cause your potassium to change with the hydrogen. But apparently this doesn't happen for organic acidosis. And I have since looked, and there are multiple articles, review articles, like even Medscape said it. Like there's like a ton of articles to talk about this. So that is not the explanation, even though that is what I thought was the explanation forever. Okay. So part of it is the solvent drag.
Sorry, Alec.
Yeah.
Sorry. May I know what do you mean by inorganic acidosis?
Inorganic, it just means so not organic. So organic molecules are like anything with carbon. So organic chemistry, the reason why it's called organic is because it's got carbon in it. So anything without carbon. So that's why I said hydrochloric acid. So there aren't that many inorganic acidoses. So okay, so hyperglycemia, so efflux. So I think Aparna was saying you got solvent drag. So that is part of it. So there is like water that comes out, right? So you have hyperglycemia, your osmolarity is high. Water is going to leave the inside of the cell to go outside. It's going to bring potassium with it. Okay, so that is part of it. I can't remember who was saying this explanation, but the other thing is that your potassium on the inside, the concentration goes up, even though the total amount does not, right? So think about it this way. Like, let's say that I had 10 potassium molecules on the inside of my cell, and I had like 100 water molecules, right? So there would be 10 potassium ions for every 100 water molecules. Now let's say that I had half of the amount of water on the inside. Even though the total amount of potassium has not changed, the concentration has increased, right? Because if I have half as much water and the same amount of solute, my concentration is now doubled. Does that make sense? So the concentration has changed because the water has changed. So the intracellular potassium has gone up. So now the gradient is increased. So now there's going to be more potassium that's going to leave the cell because the gradient is now larger. Does that make sense? Isn't that cool?
Yeah.
Come on, guys. I think this is awesome. This is the kind of thing. If you think this is awesome, you should think about anesthesia. I'm just gonna throw that out there. I'm not gonna say anything else. Just gonna throw it out there. Okay.
Does that follow the solvent drag, or are they unrelated?
That is unrelated. Yeah. Oh, you're saying could this be the mechanism of the magical solvent drag? I don't know, actually. That would be very interesting. My guess is probably not. My guess is that there is still something like that's not that, because if you think about it in the kidneys, right, your kidneys are really good at reabsorbing stuff. So my guess is that my guess is that could not explain all of solvent drag. I think there is still some like magical component of somehow when like water is being pulled out, it's going to pull out other electrolytes with it. But to me, again, that's still kind of like it's not quite at the level of cytokine storm, but it is still kind of hand-wavy in my mind. I'm sure that can be explained better though. My understanding of chemistry, I don't think is good enough to understand how that could be. Cool.
I have a quick question.
Yeah.
So, kind of afraid to ask this question, but is that probably the mechanism behind why we get hyperkalemia and kidney failure too?
The reason why in kidney failure, why your potassium is high is because you can't get rid of potassium. So remember, like your kidneys are responsible for meeting your potassium levels. If I can't excrete potassium, I have no mechanism for decreasing my potassium if it goes high.
Okay.
That is why. In other words, as an anesthesia resident, I look at a lot of potassiums, like serum potassiums, because like you have to think like, okay, should we do this case? Should we not? Is this patient gonna like code in the middle of the case? Is this a bad idea? But really, the only times that you see hyperkalemia normally are if they've got like kidney failure, and that's usually, not always, but usually. That is also the reason I think why some people in DKA have hyperkalemia. That's like another reason. All of these things are just partial explanations. Ischwan's is also true, right? Lack of insulin means you're not going to activate the ATPase. If you have low intracellular ATP, which is likely to be true, then you're also not going to have as much sodium potassium ATPase, right? So all of these things are true. My guess is that a lot of people in DKA are going to have some degree of kidney dysfunction. My guess is that would also contribute. So the goal is not necessarily to know the one right answer. I think the reason why I like talking about these sorts of questions is because these kinds of explanations are exactly what you need to be able to think through and say, oh, this makes sense, or oh, this doesn't make sense on your test. Because they're going to give you physiologic answers that you're going to have to say, oh, this is true, or this could not be true. Right? And you're going to have to make those decisions relatively quickly. Other questions? Okay. So what happens to the serum sodium when you treat someone with DKA with insulin? Patricia, what do you think?
Insulin will correct the sodium potassium pump.
So okay. So practically speaking, this is a very practical problem, right? You're treating someone with DKA, you're giving them insulin. What am I gonna have to worry about with the potassium? Is it gonna go up? Is it gonna go down? Is it gonna stay the same? What's gonna happen?
The potassium will go down.
Will go down. Okay, good. Why?
Because the pump will be restart and include this potassium inside the cell.
Perfect. So part of it is the sodium potassium ATPase, right? So what else? There's other mechanisms.
I don't know.
A good way to approach any of these questions is to say, okay, well, why was the potassium, what's the mechanism for the potassium being high in the first place? So what's the mechanism for the potassium being high in the first place that we just talked about in the last slide? Anyone want to help?
The potassium concentration gradient that was created with the water movement.
Good. So that's part of it.
Yeah.
You're going to have less free water going from inside to outside. So the intracellular osmolarity is going to be lower because there's going to be more free water, which means the potassium gradients can be lower because the potassium concentration on the inside is going to be lower. Good. And that's it. I'm sure there are other mechanisms, right? You can go with Yuxuan's. There's going to be more ATP on the inside of the cells. The sodium potassium ATPase is going to have more activity, right? All of those things. Cool. So I actually am going to save the question that I was going to go over until next time.
Sorry. Should it be less activity?
Should the
That's the
sodium
reason
potassium
why
ATPase
potassium will be
less
out.
active? Because why?
Yeah.
Why?
Because I'm thinking about it like hypoxia. Just like hypoxia, you don't have oxygen to drive to make ATP. This why you don't have glucose to glycolysis cannot happen as you're not
treating
getting
a
ATP.
DKA. So you have insulin now.
Yeah. Okay. Sorry.
So you have ATP. So you should have.
So it's just reversed.
Correct. Yeah. It's the reverse of what you said before.
Yeah.
Okay. So I'm going to save the question that we were going to go over until next time. Because I think it's a really, really good mechanism for retention because a lot of the stuff that we talked about in this are in the question. So I think it'll be a good way to solidify it for you guys. That, and I want to talk about any questions that you guys have because there's a lot. My goal with this was to try to tie in a lot of different concepts to show you that it's not like biochemistry isn't just biochemistry. It is probably the most integrated subject that you will learn for step 1 because it ties in with GI, renal, cardiac, pulm, right? We could talk about like the breathing pattern of someone. Yeah, actually, let's talk about that. Like, what would the breathing pattern of someone in DKA be? They're breathing fast, slow, normal?
They're going to breathe fast.
Fast. Okay, why?
Because they're going to try to blow off CO2 to reduce the metabolic acidosis.
Perfect. Yeah, so very good. Exactly. Yeah. So they are going to have a metabolic acidosis, so they're going to have respiratory compensation, right? So again, I mean, there's so many different ways that you guys can think about this, which is why I love DKA, because there's ties in so many different things. But because we tied in so many different things, it's also really complicated. So what questions do you guys have? I know that I did not explain everything perfectly. And I promise I won't follow it up with a question. Jolene, if you want to ask a question, I won't ask a question.
So one thing I'm still a little confused about is when we were talking about the pseudo-hyponatremia. And so I guess why would the extracellular osm stay the same if we're treating the hyperglycemia, which I would think would reduce.
Oh, that's fair. Yeah. Okay. So maybe it goes down a little bit. I see what you're saying. Yeah. But the point is that it's not going to go down. It's not going to change so dramatically as you see in hypotonic hyponatremia. So yes, it's probably going to go down somewhat over what course of time, probably not that fast. So when you immediately correct it, because the problem is that if you have someone that's hypotonic hyponatremia and you give them a solution, so let's say that the serum osmolarity is like 260. If I give you so normal saline, the tonicity of normal saline is it's a little hypertonic. It's I can't remember, 310, I think.
300?
I don't remember. It's around 300, but I think it's slightly hypertonic. So I think it's a little bit higher. If I give you a solution that itself is very hypertonic, it will correct that very, very quickly. That's the problem. What your physiologic thought process is spot on. Your osmolarity will change. They just won't change to the degree that it's going to matter. Okay. So presumably it will go down because if you correct the underlying problem that's making you hyperosmotic, you'd expect you no longer to be hyperosmotic. So I said that it was the same mainly for illustration purposes. It would probably go down a little bit. Okay. Other questions?
Thanks.
I have a question.
Yeah.
So what do you recommend we do after this lecture of DKA? Do you
That's a fantastic question. I love that question. The first thing that I would do, the absolute first thing, and this is true of all lectures, as soon as you were done with this lecture, I would go through these questions and I would make cards on these questions. The beautiful thing is, the vast majority of these questions, I even wrote down the answers for you. So you don't even have to think. You can just make cards on this. If I were to design a resource, an online resource, what I would do is I would create videos and then I would have Anki cards that are like some sort of spaced repetition system where you just click a button and it puts all of the integration there's like a list of integration application questions, and it would put all of them into your cards so that you can make sure that you can always remember these topics. Because again, if you understand the answers to these questions, it means that you have to understand the basic stuff pretty well. And then you would just like do your, if I was to design the world, that is how I would design it. I'm actually in the process of trying to design a system. It'll probably be a while until we have that kind of system where like it's videos, you can click a button and add cards, but it will be like spaced repetition. It will use spaced repetition. But yes, so whenever you do lectures, you should always watch the lecture and then go immediately back to the first slide and just make sure that all of those cards are in, all of these questions have answers and that they're in your decks so that like you can always remember it.
I have a question just kind of like going on that. For the making the cards, should like I find like when I do make flashcards for school now, sometimes the answers are so long. Should we like try and get all the information into like, or just keywords? I guess is my question.
Well, so if it's a concept, so how would I recommend doing this? In general, having cards that are too long, answers that are too long, it is not helpful, right? So it depends on if it's like if it's a detailed explanation on one point, or if it's 5 different points. If you have 5 different points, that's too much information. I can tell you in almost every single situation that is going to be too much information. You have to somehow either break it apart into multiple cards, or try and pare it down so that there's less information on it. If it's, however, like a long explanation, let me see if I can find an example here. Some of these explanations that I give are kind of long, like this, for example. This is like kind of a long explanation, right? This answer right here. That's okay as long as it's like a long explanation but like 1 or 2 points. Does that make sense on me? Okay.
Yeah, it does. Thank you.
Okay, perfect. Other questions? No? Okay. Do you guys... Okay, so for biochemistry, the topic that I chose today, von Kierke, is, I think, a really good topic for a lot of reasons. If you really think about every aspect of it, or at least the aspects of the labs, you really get to think about, most of the pathways that weren't covered in the 2 previous videos that you watched. So I think that it's a fantastic way to integrate across biochemical pathways, which ultimately I think is the most challenging, but also the most fun thing to do in biochemistry. It's also the thing that they're most likely to test you on for step 1. So in that vein, I really want to focus on the basics of these pathways. I think in general, you guys are done a disservice when you see those books with all those like different intermediates and all those enzymes and all those steps. Very few of those steps are actually tested on the exam, as you guys have probably seen from question banks and NBMEs. Most of the things that you guys are tested on, or any sort of step that's tested, usually is like a key regulated step, or it's like the first step, or there's some sort of clinical relevance. The vast majority of all the steps for the biochemical pathways will not be tested on your exam. So let me say this again. You're not expected to memorize every single little step, right? The goal is just like the vast majority of step 1, to focus on the things that are most clinically applicable, okay? I'm not going to show you a single like detailed pathway. We're just going to talk about the basics and things that are very clinically applicable, okay? So we're going to talk about cholesterol synthesis, gluconeogenesis, purine breakdown, fatty acid synthesis, and HMP shunt. Okay, so it's nice because this is like the remainder. If you were able to watch and understand the other 2 biochemistry videos, I think that this covers the vast majority of all of the pathways that you're likely to see in your exam. Again, just like every lecture, we start with integration questions. So again, if you understand these integration questions, if you're able to answer them mechanistically, it means that you have to understand the underlying pathways. So again, for all of these lectures, what I would have you, at the very least, what I would have you do is turn every single integration and application question that you see in the beginning into cards, right? The fact that you would sort of make it yourself, I think, will help you learn it and sort of solidify it more. But again, all of these questions, the goal is that you can apply these pathways so that you don't necessarily have to have memorized it in the first place. All right, so let's dig in. Gluconeogenesis. So what exactly is gluconeogenesis? Yeah, so basically you're taking intermediates that have 3 carbons or more and turning them into glucose so that you can release it to the body. This is the liver doing this. And again, as a reminder, whenever they ask you, like, where does this biochemical process take place? Yeah, if you said
the liver, about 90% of the time you'd be right. Like the liver is where, glycogenesis happens, where gluconeogenesis happens, where glycogenolysis happens, where, fatty acid synthesis, like so many of the different biochemical pathways happen in the liver. So this is no exception. What's the final step of gluconeogenesis, Natalie?
Is it making acetyl-CoA? So like pyruvate to acetyl-CoA?
Sorry, of gluconeogenesis. So you should have considered what you said, the final step of glycolysis, where you're breaking down sugar. So what's the final step of gluconeogenesis, where you're taking an intermediate and turning it into glucose so that it can be released to the body?
So glucose 6-phosphate to glucose.
Perfect. Yeah, exactly. So glucose 6-phosphatase, which is what takes glucose 6-phosphate to glucose. And so what's the final step of glycogen breakdown, MJ?
The same.
Perfect.
Concept.
Exactly. Yeah. Kind of crazy, right? It's no coincidence that the same final step of gluconeogenesis is the same as glycogen breakdown. So who can tell me why this would make sense to have the same enzyme be the final step for both?
I could try.
Okay, perfect.
Basically, when we have glucose, the way the body keeps the glucose within our body is to add a phosphate to it. And so the phosphate will be trapped inside our body. So if we want to go back and make the glucose, we have to take the phosphates off. And so that's what the phosphatase does. And so the glucose 6-phosphatase will take the phosphates off the glucose 6-phosphate to make the glucose.
That's perfect. That was very good. So in other words, you can think of this as sort of like the reverse process of the first step of glycolysis. There are basically two things that something has to be in order to cross the membrane on its own, right? It has to be small and it has to be uncharged, right? It has to be, ideally, it has to be nonpolar, okay? So a phosphate that you add to glucose, again, as the first step of glycolysis, when you add that phosphate, you're doing the opposite of that. You're adding something large and you're adding something charged, right? Both of those two properties make it impossible for that glucose to leave the cell. Okay, so glucose comes in, you put a phosphate on it, you trap it in the cell. So glycogen breakdown and gluconeogenesis both have the opposite goal, right? You're not trying to trap the glucose in the cell, you're trying to release it into the bloodstream by having it cross back through the GLUT transporters into the bloodstream so that the rest of the body can use it. So it makes sense then that that the final step would be to take off that phosphate group so that it is no longer trapped in the cell. So for gluconeogenesis, so it's a substrate. So this is something that was always confusing. So pyruvate, can pyruvate be turned into glucose via gluconeogenesis? Yes or no, and why? Heidi, what do you think?
Yes, because it's a 3-carbon chain.
Very good. Nice. Okay. Yeah, exactly. Perfect. Yeah. So the reason is because, again, we said it has to be 3 carbons or more for something to be turned in a very, very big picture sense. If something is 3 carbons or more, it can be turned into glucose via gluconeogenesis. How about glycerol?
Yes.
Yeah, so glycerol it's 3 carbons. Good. How about oxaloacetate, Anna?
Yes.
Yeah, perfect. Why?
It's also 3 carbons.
So it's actually 4 carbons. It is more than 2, right?
Yeah.
So perfect. And then how about acetyl-CoA estrin?
No, because it only consists of 2 carbons.
Yeah, perfect. Yeah. So it's like the exception to this. You know how I said everything that's sort of 3 carbons or more in a very big picture sense can be turned into glucose via gluconeogenesis. So acetyl-CoA can't, because again, it's only 2 carbons. It's really the only one. This is the most common misconception. People always think that acetyl-CoA can be turned into glucose. So the way that you can remember that is that it's 2 carbons, so it can't. Perfect.
Hello.
Yeah.
Yeah, may I know why it requires 3 carbons to be enclosed?
It's a really good question. I can't give you a good explanation other than if you look at sort of glycolysis, and there's no way to make it go backwards. But honestly, I don't have a good biochemical explanation. Someone else in the group may. I don't know. Daniel, do you have an explanation for why that is? Well,
If you try to go from acetyl-CoA through the TCA cycle back to oxaloacetate, then you lose both the carbons as carbon dioxide.
True.
So then it's just lost.
Yeah, but why couldn't you, you can go pyruvate to
Why can't you just go to
oxaloacetate. You can, add a CO2 to it. Like, why couldn't you add a CO2 to, I don't know. Chemically, I'm not sure there's a reason. I just don't know. This is just like a
Thank you, guys.
simple rule. Sorry?
Yeah, thank you.
Okay. Yeah. That's a great question. I've wondered the same thing. I don't have it's been too long since I've done chemistry. I don't have a good reason for why. There are a couple of people that are still in the room where it says waiting for name. If you guys could fill in your name, it'd be great, because that way I can call on you guys, because I'm not even sure who you are. Perfect. Okay. So glucogenic versus ketogenic amino acids. This is something that I think a lot of people get really confused with. So let's talk about this. So what exactly is a glucogenic amino acid? Okay. How about Natalie? What's a glucogenic amino acid?
I don't really know, but is it an amino acid that you can use in making glucose?
Yeah, pretty much. That was a very good yes. That's pretty much it.
Okay.
So the more specific thing is when you break it down, the thing that it is broken, at least one of the things that it's broken down into can ultimately be turned into glucose via gluconeogenesis.
Okay.
So said a different way, what does that mean? That means that it's got to be broken down into something with 3 carbons or more, right? Because we just said if it has 3 carbons or more, it can be turned into glucose via gluconeogenesis, which means that if it's a ketogenic amino acid, what is a ketogenic amino acid, Daniel Schlesinger?
Something that couldn't be turned into glucose. So that would only have like 2 carbons.
Yeah, perfect.
Be turned into ketone bodies.
Yeah, exactly. So it's an amino acid that, when broken down, can ultimately be turned into a ketone body, but not necessarily something that can be turned into glucose. So practically speaking, what does that mean? That means that it's broken down to an acetyl-CoA. Okay. So
Alec, I have a quick question.
yeah, absolutely.
On some of the old questions, they wanted us to know which amino acids can be both. Why is that important? I be thinking.
Why is it important, or how is that possible? So it's important because, it's practically speaking, it's important for a lot of things. I think the major times that you see it is when you want someone to be on a ketogenic diet. So the classic one, we'll talk about this in a little bit, but the classic one is pyruvate dehydrogenase deficiency. But that's the major one. There are some places where you really want to limit someone's gluten. And you would think, if I just starve them of sugar, their glucose is going to low. But really what ends up happening is that if you give them the wrong kinds of amino acids, they can still produce sugar.
Okay.
If that makes sense.
Great. Thank you.
Yeah, absolutely. So can something be both glucogenic and ketogenic, Ishwan?
Yes.
Yeah, absolutely. And MJ, how can that be? Why can you have something be both glucogenic and ketogenic?
Just then amino acids can break down into the acetyl-CoA or 3 or more plus carbon.
Perfect, exactly. And so what are the only solely ketogenic amino acids, meaning they're not ketogenic and glucogenic? Which are those, Daniel?
Leucine and lysine.
Perfect. Yeah, exactly. So the reason, as we sort of said before, so Daniel, can you explain again, why would you use leucine and lysine for pyruvate dehydrogenase deficiency?
In pyruvate dehydrogenase deficiency, you get all the buildup products of glycolysis, and so you want to decrease the amount of times that you're going through glycolysis. So if you give them a ketogenic diet, then you're not giving them any more extra glycolysis.
Yeah, exactly. So if you think pyruvate dehydrogenase, depends on sort of how you define glycolysis, but most people I think would agree that it's the final step of glycolysis. Whenever you have a defect in a downstream part of a pathway, right? So the last step of glycolysis, in general, you're trying to decrease things sending things through that pathway, right? So if glycolysis is defective, you don't want to send things through the glycolytic pathway. Reason being, if you do that, as Daniel pointed out, you will have a buildup of the different precursors before that final step. That's why in this case, again, you don't want to have a lot of glucose around because you don't want things to go through glycolysis. So for that purpose, you'll give someone a ketogenic diet. Perfect. So von Guericke disease, or von Guericke disease, however you want to say it. So what is the deficit in von Guericke, Manu?
It's a deficiency in glucose 6-phosphatase.
Perfect. And so what substrate would immediately build up if you had a glucose 6-phosphatase deficiency?
G6P.
Yeah, perfect. Glucose 6-phosphate. Excellent. So what pathways would increase if you had an increase in glucose 6-phosphate, Manu?
It could shunt back into glycolysis. Also, the HMP shunt's possible as well.
Yeah, totally.
And
those are the two big ones. Yeah, I mean, I guess you could glycogen, I guess too.
Yeah, that's what I was thinking.
Yeah, glycolysis and HMP shunt are the most relevant ones for our discussion here. So what pathways would be decreased if glucose 6-phosphatase were deficient, Lillian?
Would gluconeogenesis be one?
Okay, yeah, good. What else?
Glucose 6-phosphatase. Also making glycogen?
Maybe not making glycogen.
Oh, would it be would it be breaking down glycogen?
Yeah, totally. So again, both of these processes have the same final step that same final step, right, glucose oxidase, is the same exact thing that is deficient in von Gierke. So it makes sense then if I had a deficiency in glucose oxidase that glycogenolysis and gluconeogenesis would both be decreased, right? So what time frame would von Gierke become symptomatic? Meaning, after how many hours of not eating would you start to see the symptoms? Daniel, can you explain what time frame would you be symptomatic in von Gierke?
After about 3 or 4 hours.
Good.
That's about how long your glucose lasts from your diet.
Yeah, exactly. And can you think of a practical way that you can remember that it's about 3 to 4 hours?
I saw what you wrote in for parents, but
yeah. So
I'm a long way off from that. So
it's true.
Doesn't apply to me.
Yeah. Can you explain though? But
yeah, I guess apparently if you're a parent, then you got about 3 to 4 hours in between every time that you feed your kid before they start crying.
Yeah, exactly. And like you kind of want them to cry too, because like it means it's like they're hungry. So you can make sense of this because again, dietary glucose lasts about 3 to 4 hours, right? So they'll like when babies are born, they don't have well-developed glycogen stores, and so they are basically reliant on their dietary glucose in order to keep their blood sugar up. So you have to feed newborn babies every 3 to 4 hours. And it is like the most exhausting thing. So if you're like a new parent, like you will definitely remember that. If you don't, God bless you. And probably someday you'll know what that feels like. So do you have like a visceral understanding of this now? Patricia's like, yeah, I am never going to forget that von Gierke would start presenting at about 4 hours. That was pretty much how much sleep she got. That's pretty much how much sleep I got when my child was first born. Okay. At what point would you become symptomatic in like a VLCAD deficiency or like a fatty acid dehydrogenase deficiency? What do you think, Lillian?
However long the fatty acids last for.
Kind of. So what's the problem in a VLCAD deficiency?
I'm not quite sure, but I just am going off of what you said about fatty acid because I'm not actually sure what VLCAD stands for.
So VLCAD stands for very long chain acyl-CoA dehydrogenase.
Oh, okay. So would that be the enzyme that's breaking down the long chain fatty acids?
Exactly. Yeah, the very long chain. So that have really low, lots of carbons on them. Exactly. So when would you become symptomatic if you had a VLCAD deficiency?
When after you don't have your storage of the very long fatty acids anymore.
Oh no. So this is actually before that. So it's usually 12 to 16 hours. The problem is that you're not able to use. So sort of in the same way that von Gierke, you can't use glycogen and gluconeogenesis to bump your sugar level. And so you'd present as soon as you like lose your dietary sugar, like all the dietary sugar. In von Gierke, you present as soon as you can't use your glycogen stores, basically. When you're starting to rely more on fatty acid oxidation, when you would normally start to rely on fatty acid oxidation, not after you've been relying on fatty acid oxidation, if that makes sense.
I'm still a little bit confused in terms of, so are you saying that like in von Gierke, like it's not how long, like I'm trying to draw a comparison. So it's not how long your glycogen storage lasts, it's how long the glucose is in your.
So like when the baby drinks like milk, so human milk lasts about 4 hours. Is about how long it takes before you've absorbed it all and it's gone from your
I
system.
see. Okay.
So after that's gone, then normally, like for you and me, if we don't eat for 4 hours, we don't start convulsing. We don't get symptomatically hypoglycemic. The reason why is because we have glycogen stores that we can use.
Okay.
Babies with von Gierke, or like really little babies, can't do that. They don't have much in the way of glycogen stores. So once that dietary glucose is gone and their body's used it, they don't have another easy source of glucose.
Okay. I misunderstood. Okay, that makes sense. So in this other deficiency, the very long chain, in this deficiency, it would be when like you don't have any more circulating long chain fatty acids. So it's not about the stores.
Well, so it's not when you don't have so you will have circulating long chain fatty acids. The problem is that you can't break them down to use them.
Oh, okay. So it's similar that like when you don't have any more of the other energy.
Perfect.
Okay.
Yeah,
that makes sense.
exactly. So once I run out of my other energy sources, then I will become symptomatic here. Because normally you would start to use, you'd be able to use your fatty acid oxidation after your glycogen stores have been used up. But in this case, you're not able to do that. It often occurs following infection. So how can you make sense of the fact that it happens sort of 12 to 16 hours often after an infection, Manu?
Are we talking about the symptoms or
Oh, no, sorry. I mean the timing.
after an infection? I guess that's when, let's see, I guess maybe like the body's trying to like rebuild. I don't know if that's very simple, but
So in general, so glycogen stores last between sort of like 24 or 28 hours, like somewhere around that. Again, if you're not like exerting yourself a lot. In viral illness, I mean, I can tell you, I just got over a really, really bad cold. I'm still getting over a really, really bad cold. And outside of like my insatiable thirst for Thai ginger ale during that time period, like I didn't really have much of an appetite. I just didn't eat that much. But especially if you have like a fever, your energy requirements go up, right? So 24 hours is how long your glycogen will last if you're just kind of sitting there, not doing anything in a full glycogen stores, right? If you're not eating and if you're, have a fever and your body's sort of revved up metabolically, then your glycogen stores are going to last that much less. This is why oftentimes people with like fatty acid oxidation deficiencies, so like MCAD, VLCAD, like that sort of thing, oftentimes they'll present either after viral illness or after some sort of semi-strenuous exercise. But in both cases, the idea is that you're sort of burning through your glycogen stores faster so that you will start to rely on fatty acid oxidation that much sooner, right? But all things being equal, you'd expect to maybe start to become symptomatic after around 24 hours. Although again, you would still have gluconeogenesis, so it's not like you would have no sugar. All right, so cholesterol synthesis. So what are the substrates for cholesterol synthesis? Anna.
Cholesterol synthesis from steroids.
No. What goes into making cholesterol itself? Not what can you use cholesterol to make?
I'm not sure.
Can someone help?
Acetyl-CoA.
Yeah, exactly. 18 molecules of it, which is kind of crazy if you think about it. But it's like just a bunch of acetyl-CoA. Okay. So what's the key regulated step? Patricia, what's the key regulated step of cholesterol synthesis?
HMG-CoA synthetase.
Very good. Well, HMG-CoA, yeah. Reductase, or I think it's also photosynthase. Wait, is that? Yeah, I think it's, reductase. So what drugs inhibit HMG-CoA reductase?
Statins.
Yeah, it's perfect. So what's the mechanism of statins decreasing LDL cholesterol? Lillian.
So the statins, they block the HMG-CoA reductase. If you think about it, like in the liver, like if it's blocking the cholesterol synthesis, then those cells will increase they're going to make more of the LDL receptors and put them to the surface of the cells. So they're going to, because they're trying to maintain homeostasis of the cholesterol inside the cell. So because they're not making it as much, they're going to take more from the plasma. So then decrease your circulating levels of LDL.
Yeah, perfect. Yeah. So remember, cholesterol is, we think of cholesterol as like this bad thing, but really cholesterol is a necessary thing for our body. So remember that cholesterol is necessary for the liver, right? So cholesterol, by definition, cholesterol forms the basis of all steroid hormones, but it's used for a lot of other things, bile salts, and it's used in cell membranes. So you need cholesterol. So if you would block making cholesterol, then your liver is going to need to get the cholesterol from somewhere. So LDL has the majority of cholesterol in your bloodstream. And so you will end up, in order for your liver to get more cholesterol, it'll take up more of the LDL cholesterol to be used in biochemical pathways.
I have a question. Is this going to affect HDL level as well?
Does it affect HDL levels? I think statins do increase your HDL levels. Yeah.
Oh, okay. Because HDL is the one that's responsible of carrying the cholesterol from the blood to the liver, right?
From like peripheral tissue to the liver. That's correct.
Yeah.
Yeah, that's a good question. I want to reemphasize this. So this is a really popular question on step one. They're going to ask you the different variants of the question, what's the mechanism of statins on LDL cholesterol? It is not that, the reason is not because you are decreasing making cholesterol, which is true. The reason why your LDL cholesterol decreases in your bloodstream though is because you have an increase in the LDL receptors. It's one of those crazy things where they thought sort of simplistically when they made statins in the first place that just cholesterol meant bad, like all cholesterol is bad. So they were just like, if I stop making cholesterol in my liver, then, and they used type 2A hyperlipidemia as an example, or as sort of like the basis for this. It turns out that just decreasing someone's cholesterol does not decrease mortality. It does not help with coronary artery disease. What benefits is decreasing the LDL cholesterol. They didn't know this at the time, but the statins still helped with mortality and helped with coronary artery disease. And so they just got lucky. They thought that it was just the total cholesterol going down that would be the reason why people had less coronary artery disease, but really it was because of decrease in LDL cholesterol. And one of those very fortunate sort of accidents in medicine, which is, really common. Okay. Fatty acid synthesis.
Alec?
I
have a question. So like in using like statins and stuff for like type 2 dyslipidemias, so they have an absent LDL receptor or like a defective LDL receptor, would the drug still help in patients like that?
It's a good question. What do you think?
I'm not very sure because if it's I'm not sure if it's only just an absence or if it's a defective LDL receptor. Because if it's just the absence, I mean, it would work. But if it's defective, that's what I'm not like.
Oh, I see what you mean. Depending on what kind. I don't know. I mean, I assume that, again, in medicine, nothing is sort of like all or nothing.
Okay.
So if we say it's like defective, it doesn't necessarily mean that there's like no function. And if it's like deficient, it doesn't necessarily mean that there's like zero of it. But I don't know. It's a really good question. I would expect that it wouldn't help much.
Okay.
It may help like a little bit. But in general, those are exactly the kinds of people that develop coronary artery disease like really early. Okay, so fatty acid synthesis. What is the substrate for fatty acid synthesis? Heidi?
Acetyl-CoA.
Acetyl? Lots of them, right? Just like cholesterol.
A string of them, yeah.
What's the breakdown product of fatty acids?
It's acetyl as well.
Yeah, exactly. Right? What do you know, right? If you think of a fatty acid is basically just a lot of acetyl-CoA strung together, right? You just add a bunch of acetyl-CoAs together. So it makes sense that when you break it down, you're just going to get acetyl-CoA. How many carbons are in a fatty acid and why, generally speaking, Manu? Now, how about MJ? What do you think?
C16, so 16. Sorry.
It totally depends. So it's an even number, right? Yeah. So this is the whole reason why there's like a VLCAD and an LCAD and an MCAD, right? The very long chain in the very like VLCAD, the long chain in LCAD, the medium chain in MCAD, right? The length that we're talking about, right? Medium, long, very long, just refers to how many carbons are in that fatty acid, right? So you can explain why it's an even number, at least in humans. So any fatty acid that we make is going to have an even number. You can understand this because, again, how many carbons does acetyl-CoA have? Acetyl-CoA has 2 carbons, right? So it makes sense that if I'm stringing together a lot of acetyl-CoAs, that the fatty acid chains would grow by 2 each. All right. So Yvonne, you're here with that.
So it makes sense to me that any fatty acid that we ourselves synthesize can be even. Remember, we can still like take in odd number fatty acids, right?
That is correct.
Because like other like plants and stuff can make odd number. And then isn't that like the one exception to like why you can actually get like glucose technically from fatty acid? Because if it's an odd number, then you're left with that 3 carbon at the end. I like randomly learned this.
Yeah, that's
from
true.
My classmates. Yeah,
that's true.
Okay.
Because the vomit pathway feeds into the TCA cycle. So yeah, you'll get a 4-carbon intermediate from. Yeah, I guess I never really thought about that. Yes, so that is true. So non-human fats is a chance that you could turn a fatty acid into. I mean, fats themselves can be, right? The cholesterol and triglycerides can be turned into.
Yeah, I guess just specifically like with a fatty acid, because when you break off all the acetyl-CoA, then if it's odd number, then you're left with a 3-carbon. I think it's like propanol-CoA, and then that, because it's 3-carbon, can be turned into glucose.
Yeah, perfect. Yeah, exactly. All right. So since you are talking so expertly about biochemistry, Lillian, can you tell us what the cholesterol level would be in someone with von Wieren's?
Okay, let me think. So let's see. So the von Wieren's, these were the people with the glucose 6 phosphatase deficiency, correct? Is that the disease? Okay, so that means that you would have a buildup of the glucose 6 phosphate, and then you would increase processes like gluconeogenesis and like.
So we said gluconeogenesis would be decreased, right? Because
it'd be decreased because you don't have.
but what would be increased?
So glycolysis would be increased because that makes sense. So let me think how that relates to cholesterol. Oh, okay. So if you have more glycolysis, then like the downstream product would be acetyl-CoA, and that's what cholesterol is being made out of. So I guess you have high levels of cholesterol.
Very good. Nice. That's very good. So I learned, you can sort of tell two things. One, you didn't necessarily read the PowerPoint presentation at great detail before this, which is fine.
Yeah,
But
I only got through like
no, it's okay. No, I'm not. That's not a criticism, because what I'm going to say next is you did an excellent job of working through this. And it was because you had a good understanding of the pathways. And again, it wasn't because you'd memorized every single step in glycolysis. You knew the important parts. You knew that you turn glucose into acetyl-CoA in glycolysis. And you knew that acetyl-CoA, I couldn't tell you all the steps in cholesterol synthesis. Like I looked through them again recently when I was making this, and I was like, oh my God, there's just so many things that, like, you guys just don't need to know. It's just completely unnecessary. But if you know that acetyl-CoA feeds into cholesterol, and that glucose, when broken down, comes acetyl-CoA, then it makes sense. It should make absolute sense to you that when you have Vandirki, you will have an increase in cholesterol. So that was really good. Okay. So what would be the triglyceride level then in someone with Vandirki? Daniel?
The triglyceride, that would also be elevated.
Yeah, perfect. And why?
Because from the increased glycolysis, you get the increased acetyl-CoA, and then that just gets fed into making fatty acids, which can go into triglycerides.
What is a triglyceride? What's it composed of?
It's phosphate backbone plus three glycerol molecules.
Try again.
Glycerol backbone with 3 phosphates. No.
Close. So it is a glycerol backbone. That is true. What's the tri refer to? It's kind of confusing. So what you're trying to do is you're trying to like understand it based off of the word. The word, however, triglyceride is quite confusing. Really, what they should say is triacylglycerol. That's like the true chemical name. So what is triacylglycerol?
3 acyl groups plus a glycerol.
Exactly. And what is an acyl group?
It's a 2-carbon group.
That's acetyl. Acetyl is a 2-carbon group, right? Acetyl-CoA. Acyl-CoA, again, is just a fatty acid, right? You ever wondered? So again, VLCAD. Let's break it down. Very long chain.
Right.
Acyl-CoA dehydrogenase. So the acyl-CoA dehydrogenase is the fatty acid. That's what they're saying. It's a fatty acid dehydrogenase. So triglyceride, again, I intentionally left it as triglyceride, not triacylglycerol, to kind of,
right,
like confuse you guys. But remember, a triglyceride is just another word for triacylglycerol. Glycerol is a 3-carbon back. So it has 3 attachment points for fatty acids if they want to attach. So it's triacylglycerol just means 3 acyls attached to a glycerol, meaning 3 fatty acids attached to a molecule. Very good. All right.
Also, like with the glycerides being increased, don't you also have like, okay, with Vandirki's, because you have like hypoglycemia, your glucagon and epinephrine would increase. That would like stimulate like your HSL, and then like that breaks down like your triglycerides to fatty acids, which will also give you that increase in fatty acids in the blood, right? Or
that's true. Yeah, absolutely. Yeah, I'm not saying that these are the sole reason. So you're pointing out that because you're hypoglycemic, then you'd have like low insulin, so disinhibition of hormone-sensitive lipase and increase, breakdown of triglycerides and release of fatty acids into the bloodstream. Absolutely. I think that's fantastic. That's very good. I'm impressed that you would think of that. Yes. So I'm bringing up these pathways not necessarily because they're the only pathways, because they're certainly not, but because you can use them to connect the different biochemical pathways. But yeah, I think your connection, I think that would also make a great connection. So that was very good. Okay, Vandirki and lactic acid. So what's the lactic acid level in Vandirki and why? Manu.
So the lactic acid levels are higher.
And what?
So the way I thought about it always was because, let's see, you have a deficiency in terms of exporting the glucose out of the hepatocyte, right? So you're going to get a flux, and like we said earlier, you can flux down 3 pathways. So if you're making a lot more, or if you're fluxing down glycolysis, you're going to have a lot more of the end products, pyruvate. And if you have a lot more pyruvate, you're going to shunt some of that pyruvate into lactate, which will then become lactic acid.
Very good. Perfect. Yeah. So again, this is just like Lillian. I don't think you read the presentation much beforehand, but what you did was fantastic, right? You were able to use a big picture understanding of the pathways to figure out the answer. You don't have to know every single part of glycolysis to answer this question. Just like you don't have to understand every single step of glycolysis in order to answer questions on step 1, right? It's the big picture and the clinically applicable stuff. Perfect.
Alec, I actually have a question.
Sure.
Sorry.
Yeah, go ahead.
I'm wondering would you also get alanine production?
Absolutely.
Bronchiectasis.
Yeah,
Okay.
definitely. So you don't routinely measure alanine in the blood, but yeah, I mean anything that would be increased if you had to build up a pyruvate. So I mean it's like what builds up in pyruvate dehydrogenase deficiency, the same stuff, lactic acid, alanine, stuff like that. The other thing to note again is that what's the purpose of making lactate normally, right? When you're running, why do you make lactic acid? For
anaerobic metabolism.
Yeah. What do you think?
Oh, what about it?
Yeah. So in anaerobic metabolism, why is making lactic acid beneficial?
To regenerate your NAD.
Yeah, perfect. So in anaerobic metabolism, and why would you have to regenerate NAD specifically in anaerobic conditions?
Because then you can't go through oxidative phosphorylation. And so you can just go back through glycolysis again.
Perfect. Yeah. So remember, normally in the presence of oxygen, you can do electron transport chain. So you feed in NADH, it donates its electrons, and you will be left with NAD+. That NAD+ can then go back into glycolysis to allow for glycolysis to occur. If you don't have oxygen, you can't do the electron transport chain. And if you can't do the electron transport chain, you can't use up all of that NADH. And so in order to make in order to make ATP, you still have to do glycolysis. But if you have a buildup of NADH, you're not able to do that. So I don't want to go too far in depth in this because we talked about this in the previous lectures, but in the general sense, this is what I want you to remember. It's not just the pyruvate's up. It's also that, remember, your NADH is going to be up in this situation as well.
Alec, can I ask you just a quick follow-up question?
Always.
So I understand that what we just said, that how we get an increase in lactate in terms of what's happening at the hepatocyte. One thing I was wondering was, do we also think about in terms of just the lactate levels in the serum, the Cori cycle's not working either, or it can't work because the muscle is still kicking out lactate, but then the lactate gets to the liver and it can't be converted to glucose. Is that a correct way of thinking about also why lactate goes up?
Because you're limited in how much your liver can process. So why would your liver be limited in how much it can process the lactic acid? Oh, because its gluconeogenesis is messed up.
Yeah, exactly. So I was thinking
Interesting. That's really good. Wow, well done. So this is really pleased. This is really good, you guys. You guys are making really good connections. I had not thought about that, but that also makes sense. So,
sorry, go ahead.
So I think what Manu is saying is that lactic acid is shuttled back to the liver and it undergoes, because again, it's a 3-carbon intermediate, so it can undergo gluconeogenesis. That's how you can it's one of the ways you can sort of reuse it, you can process it. Gluconeogenesis is going to be affected, however, in von Gierke, because again, we're blocking the final step of gluconeogenesis. So not only would you produce more lactic acid, but you would also be able to process it less effectively because you're not able to turn it into glucose in the liver. Well done. Very good. Man, this is it's a really, really good thing.
Can you re-explain the connection with the Cori cycle though?
Yeah, so that's what I was just kind of thinking about was you still have the Cori cycle occurring. Basically, the muscle is still producing lactate, which is being shuttled to the hepatocyte. Once it gets to the hepatocyte, that's processed. The lactate's processed back to pyruvate, and pyruvate goes to glucose. But what I was thinking was, if we are knocking out the to glucose step because we've inhibited gluconeogenesis, you would expect a backup into the serum. Does that make sense, Alec?
Yeah, that makes sense. Because the idea is, it's just
with
anytime
the lactate from the muscle, you mean?
Yes. Yeah.
Oh, I see.
Anytime you inhibit the final step of something, all of the prior intermediates will go up. If you are limiting the production of glucose from lactic acid, then the lactic acid sort of part is going to back up. And so since some of the intermediates involve lactic acid in your serum, then you'd expect to have an increase in lactic acid in your serum. It's sort of like if you have a deficiency in, what would be a good example? If you had a deficiency of, so what's the key regulated step of fatty acid breakdown? Anyone?
Carnitine.
Yeah, perfect. Yeah. So carnitine acyltransferase. So the carnitine shuttle, right? So when you have a carnitine deficiency, you'll have an increase
in like fatty acids in your bloodstream. Because again, they're sort of stuck in your bloodstream because they can't cross into the mitochondria. Okay, HMP shunt, also known as the pentose phosphate pathway. What are the two phases of the HMP shunt, Natalie?
The oxidative and the non-oxidative.
Perfect. Yeah. You say that as a question. You should say that as a statement. Oxidative and non-oxidative. Perfect. MJ, what is the purpose of the oxidative phase?
It's make the NADPH with G6PD.
Yeah, perfect. Yep. And then what's the purpose of the non-oxidative phase?
To make ribose from fructose 6-phosphate.
Yeah, pretty much. I mean, there's a lot of different byproducts there's a lot of different intermediates that you can make, but the most important one is the ribose 5-phosphate. And so what's the ribose 5-phosphate used for then?
It's the backbone for PRPP.
Yeah, exactly, which is then used for
DNA synthesis.
Yeah, DNA and RNA. So you know how DNA is deoxyribonucleic acid, right? The ribo is just this ribose sugar. So this is how you get the ribose in DNA, or the deoxyribose in DNA and the ribose in RNA. Perfect. So purine breakdown. Again, we're going for big picture stuff. So Anna, what are purines? What are like the names of the purines?
The adenine and the guanine.
Adenine, guanines. How about pyrimidines, Anna?
CUT, cytosine, uracil, and glutamine.
Yeah, perfect. Yeah. So what are the purines? What are purines ultimately broken down into, Heidi?
Uric acid.
Yeah, perfect. All right. Via what enzyme, Heidi?
Oh, I'm blanking on that. I don't know. Being oxidized?
Yeah. Perfect. Oxidase. Okay, so von Gierke and uric acid. So what would be the uric acid level in von Gierke and why? Lillian.
Okay, again, you're having a deficiency with the glucose 6-phosphatase. So you have a buildup of the glucose 6-phosphate. And in this case, we're talking about the AMP shunt. With glucose 6-phosphate, you can go through that more. And so you would eventually get more purines, and you would break down the purines more and get high uric acid levels.
Perfect. So in other words, very big picture sense, if you have high glucose 6-phosphate, you're going to have more HMP shunt, more ribose, more purines, more purine breakdown, more uric acid. This is good. This is really impressive. I have got to say, I mean, maybe it's just like your collective knowledge is so good, but like you guys are doing very well. I'm impressed. I was the biochem TA at Stanford, and man, the students, I mean, we're good, but I don't think they understood it nearly to the level that you guys did. And they were like studying it like intensely. This is really good. Okay, questions before we move on to the actual like questions of the basic part of this.
I have one question, but it's like way back into the other, in the early slide. Sorry, just to go very quickly back to the VLCAD deficiency. If we didn't have an infection, just because the glycogen stores usually last for 24 to 28 hours, would the symptoms like in a person that wasn't ill like present after those 24 to 28 hours instead of the 12 to 16?
That's a good question. They would, it's tough, right? Because you still have gluconeogenesis. So, I mean, in theory, yes. But again, it's not just like that you run out of glucose stores. It's that you become so like symptomatically hypoglycemic that you start to see the symptoms. Okay. So I would say, practically speaking, so yes, in theory, yes. Maybe not after like 24 hours. It would probably be longer, to be honest. But practically speaking, they are going to, in a question, they're going to give you something that's going to be a stressor to the body, either increased demand because they're like working out or walking or hiking or something, and or a decrease in intake, like in a viral illness.
Okay. And then in those cases, because you're like either expending more energy or like you need more energy, or you're not taking as much in, it's going to be the 12 to 16 hours because you're going to have less of the other.
Yeah, but again, it is variable. The only point I want to make with the timing is it's significantly longer than it takes to present with von Gierke.
Oh, okay. Okay.
I would not get hung up on the specific number. If it's like, oh my God, it's like 20 hours, there's no way that could be a big alkali deficiency. That does not make any sense. And the other thing to note is that the younger you are, the earlier you'll present after fasting, right? Because again, same reason, your liver is much more mature. You won't have the glycogen stores. You won't have the ability to do as much gluconeogenesis. So there are, in researching this, I found like there are basically recommendations for how long you can fast for with a fatty acid oxidation deficiency. The time frame increases. I think when you're like a baby, they say like you shouldn't fast for more than 3 to 4 hours. But when you're an adult, you can go much longer.
Yeah, that makes sense. Thanks.
Other questions?
I actually have a question. How do you differentiate between like an MCAD and like a Zellweger syndrome? Because like in both cases, you're going to have Zellweger. It's like Zellweger, where you have like a, yeah. So like
I may have heard of that once, but what's the deficiency?
it's like where you don't have like functioning peroxisomes and you need the peroxisomes to like degrade like the fatty acids. So I'm trying to figure out like how do you differentiate between that and the MCAD? Because like at the end of the day, it's still gonna have both increased, like the very long chain fatty acids.
I don't know. So you're asking from like a practical like step 1 standpoint, I assume, how would you diagnose it as like genesis? So they couldn't, you're right. I don't think that they could give you, I don't think that they could give you only a time frame of fasting and then the symptoms. They would have to give you something else. I presume, in general, I don't think they're going to ask you like to differentiate between it. They're not going to, in the answer choices, there's not going to be LCAD, VLCAD, and MCAD, right? Because the presentations are going to be almost identical. So it would have to be, they'd have to give you something else to differentiate between them. So I think it would be very unlikely that they would make you make this choice in the first place.
Okay.
I think it's highly unlikely because, again, I think there would be so much overlap in the presentation. Because, again, a group of experts has to unambiguously come to the right answer without knowing, like, the answer choices.
Okay.
So, that would be split like 50-50. So the way that you would find out, though, is, and the way that it's done, like genetics, is you look at the length of the fatty acids in the bloodstream. CAD is like, I think it's like 12 to 16, and LCAD is more than that, and DLCAD is more than that, and paroxysmal deficiency would be even longer. Fatty acids that you find. Other questions? Yeah, great question. Who is it? Yishuan? Someone wanted to ask about chronic symptom injury. Who has about potentially? And I will answer.
But yeah, I could ask, like, how do you differentiate cognitive deficiency with MCAD deficiency? Because I read that cognitive deficiency patient will have prominent hyperammonemia, and I didn't know how to connect that.
A carnitine deficiency with hyperammonemia?
Yeah, like, that will lead to hyperammonemia.
I would not have expected that.
Yeah, I read too.
Are you sure it's not OTC deficiency?
No, it's carnitine deficiency.
I don't know. I don't know. Does someone have an explanation for that? I don't know. Or it's not.
Alec, something that I came across for an answer for a question was that there was liver dysfunction associated with the carnitine deficiency, which then presents with the hyperammonemia.
Okay.
So if you had liver failure, then you'll have hyperammonemia.
Okay.
I see. So I assume that you got this from like first aid or something. This is why I hate this thing.
Yeah.
It's like the problem is that like it would have been much easier to say liver failure. If that is true, if that explanation is true, it would have been much easier just to say liver failure. And then you can sort of like connect the dots yourself as opposed to focusing on like a single thing.
But first, I didn't mention that. I got it from a book.
Oh, okay.
Yeah. Thanks, Manu.
All right. So let us go through this question together. Who would like to be brave and start?
I can start.
Let's do it.
2-month-old girl presents to the physician with a month history of convulsions 3 to 4 hours after breastfeeding. So we know that it's a very young girl, and we're going to focus also on the timeline they give us. That's 3 to 4 hours, and that's probably the same time that your glucose levels begin to fall after you finish, and so yeah, that's and then you did say earlier that babies don't have like glycogen, so I'm going to think that they're probably just starving at that point without any good source of glucose.
Yeah. So what do you think the diagnosis is at this point?
Probably one GERD.
Yeah, that would be, yeah, exactly. Because again, the timing, they can't lie to you about the timing. I mean, it's crazy how often you can figure out the diagnosis just from the first sentence. We'll see. But again, that'd be the thought. Her mother, so who wants to do the second sentence? Anna, what do you think?
Her mother reports that she becomes considerably more irritable when she's hungry than her older brother. Okay, so she's noticing a difference from her other siblings, so she thinks something's wrong. And so she's more irritable before feeding. So I'm sorry, what am I trying to do here?
So again, when you read a sentence, there's two things, right? You want to figure out like what's the purpose of the sentence, what are they trying to tell you? And the second part is, what does this mean in context?
Okay, so she thinks something's wrong, and because she's irritable, That could be a result of, we already considered bond therapy, so the G6P is deficient.
Can someone help?
Is it because that you could tell that it's a metabolic problem?
Okay, how?
Because she's more irritable when she's hungry. So like she's already depleted all her glucose from the, after 3 to 4 hours of the breastfeeding, and now she's hungry again.
Yeah. So good. So what I think you did is you sort of skipped ahead to the second step, which I think is appropriate, and you sort of took this in context, right? So the first, like the sentence itself isn't like super revealing. Irritability is it's sort of like fatigue, right? There are so many things that could be, like the differential for irritability. It's such a non-specific sign. It'd be hard to tell sort of like what it meant. Just like if someone comes and says like, oh, like I'm tired. I mean, it could be anything, right? It's very non-specific. However, taken in context with the first sentence, the thought would be, okay, maybe this is something metabolic because, it's affecting her more than the sibling. So maybe, if she has a genetic deficiency and the sibling doesn't, that could certainly explain it. Good. Heidi, physical exam demonstrates hepatomegaly in round cheeks. What do you think?
It would still support our original hypothesis that it's Von Gehrig's.
Okay. Why?
Because you get hepatomegaly in it, and
why would you get hepatomegaly?
Because you get the because you get the glycogen is not being broken down. You just keep making more and more and more of it. So the liver has nothing. That's why you get a larger liver.
Yeah, perfect. I mean, that's certainly part of it. I presume like liver damage itself can cause the liver to enlarge. So there are other things too. But yeah, good. That was the first thing that I thought of. Why might she have round cheeks?
Would that be from the increased acetyl-CoA? And so you're going to have fat deposits around different areas of the body.
Perfect. Yeah. Again, a lot of these things, I don't think that it would be very difficult to make an experiment that would definitively prove that the round cheeks are from an increase in triglyceride production, right? There's like ethical and, it's difficult to make those kinds of associations. But the beautiful thing is that you were able to come up with a good, solid biochemical explanation for why she might have round cheeks. That's great. Okay. Round cheeks equals a normal baby. You would think so after you saw my daughter, or actually me. I had like super round cheeks. So hopefully, but I think they mean, like more round than normal. But thank you, Manu. Okay. So after a 4-hour fast, serum studies demonstrate hypoglycemia, lactic acidosis, hypercholesterolemia, and hyperuricemia. So who wants to, we'll have someone explain a couple of these sort of together. So MJ, why would you have hypoglycemia and lactic acidosis?
It's like our said, we cannot break down the G6P into glucose, so there's more G6P in our hepatocyte, and it's go down to the glycolysis or NADH. So that's why we have the lactic acidosis. And for the hypoglycemia, it's kind of like we cannot release the glucose into our body, so it's low glucose level in our blood.
Yeah, very good. Excellent. And then Natalie, why do we have hypercholesterolemia and the hyperuricemia?
It's how we said earlier about how the increase in glucose 6-phosphate leads to increasing glycolysis, and then the increase in acetyl-CoA making more and more cholesterol. And then with the glucose, the increase in glucose 6-phosphate being shunted into the HMP shunt, giving the ribose 5-phosphate, and then that going into the purine synthesis, and then making more uric acid.
Perfect. Excellent. I mean, it's like this question almost feels unfair now, right? You guys have such a good understanding of the biochemistry. I will say though, this is exactly the kind of question that most students that haven't like talked about this to the level that you have struggle with. I mean, it's crazy. You guys, I mean, I don't think you understand how well you understand this topic right now. This is really good. Okay. What's the standalone question here, Patricia?
2-month-old girl present to physician with a month history.
That's the standalone question. Remember, we talked about this. The stand-alone question.
Oh, for this sentence?
For the question. So, deficiency of which of the following enzymes is most likely the cause of this patient's disorder? So, that's not a standalone question, right? I can't just ask that and you would know the answer. So, what is the standalone question here?
What is the cause of the starvation convulsion in the 2-month-old girl? No?
Because that could be a lot of things. That's not really a standalone question. Who would like to give this a shot?
What enzyme is deficient in hunger?
Perfect. Exactly. That is exactly what they're asking you, right? If I came up to you in the street and said, hey, what enzyme is deficient in von Kierke? You could answer that, right? But if I said, hey, deficiency of which of the following enzymes is most likely the cause of this patient's disorder, no way you can answer that. Okay, so what's the answer? Okay, so we know this. Okay, so let's eliminate some of the other ones. So why is
phosphatase?
Perfect. So why is fructokinase wrong?
Because the presentation would be different. The baby would have issues with more fruits and instead of being hungry instead. It will present after feeding, not after feeding the baby with fruits and stuff like that.
Perfect. That's really good. Very good, Doris. Okay, why is glucose 6-phosphate dehydrogenase wrong? Anyone?
Show it. Sorry, go ahead.
By giving a drug like a malaria drug or fava beans, or it'd be a different presentation. It might not even. Yeah.
And why does it present after after eating fava? It's funny. I ate fava beans for the first time when I was traveling in Southeast Asia. They were really good. Anyway, so I was like, oh my god, thank God I don't have a G6 deficiency. But yeah, why after fava beans? Biochemically, why does it make sense?
Is it B50? Does it have to do with being like an oxidant?
Being an accident? What do you mean?
Oxidant.
Oh, oxidant. Yes. Yeah, that's a good. What does that mean?
So you would have, I feel like what I understand with the G6PD is the fact that you're not able to reduce your glutathione, which is the oxidants for your RBCs. And so you have more free radicals in the body and stuff. So that's why you have the anemia.
Yeah, it itself is not an oxidant. It itself is an antioxidant. All right, we've got one more.
Also, you could rule out that because it's X-linked recessive.
Oh, getting fancy. Yeah, that is true. That is good.
I mean, you can't rule it. I guess you can practically.
Yeah, I mean, unless they tell you something funky. Oh, this is a good one. This gets back to our dynamics discussion from a couple weeks ago. Under what circumstances could this girl present with G6PD deficiency, genetically? What would the answer be?
Skewed inactivation.
Perfect. Exactly. Perfect. It's unfortunate pattern of X inactivation. I don't know. There's different ways of saying it, but basically it's the good X gets inactivated more than it should. So you're left with more of the bad X active. Perfect. Well done. Nice. And again, the classic situation for that is you have a mom who has a son that has a Duchenne's or something. So something X-linked recessive. And so the mom starts presenting with symptoms of Duchenne's, but at a much later age. Because again, they shouldn't normally present with those symptoms. And so the answer is always in those situations, unfortunate pattern of X inactivation, or more of the good X's get inactivated. That was good. Well done, man. I'm really pleased with how deeply you guys are integrating. What do you think? How have the mentor-led sessions been? Do you think that's helped, or do you think it's just you guys are just getting better just because?
I bet either have.
I found them really helpful. Yeah.
Yeah.
Awesome. Just because of why?
I liked how when I went to Trauma's or Christopher's session, it was just he broke it down by line, and it was almost and he was very explicit in terms of how we were building the case. I really like that. It was explicitly clear, in terms of our interpretation, and I enjoyed that part. Yeah.
Perfect. That's awesome. Yeah. The whole reason why I wanted to have that in the first place was, the more practice you guys get, I think you guys are seeing when you have live feedback on how you're doing, the more of that live feedback you have, the better you'll do. So highly, highly recommend. Max has a session this afternoon. I would highly recommend going. He is really good at interpretation. Really, really good. Okay. Dana Schlesinger, read the first few sentences and walk me through.
15-year-old boy gets lost while hiking in the wood. He is found by fellow hikers 22 hours afterwards, convulsing on the ground, after which he is emergency transferred to a nearby medical facility. I think from the first few sentences, we get a sense that if he's found 22 hours after being lost convulsing, so presumably he's been out of food, maybe. He's alone. He's maybe some kind of problem like that because he's alone in the woods. But also it took this long, so it's more of a longer term process. Maybe if something had occurred earlier, then he would have presented sooner. I don't know, I guess he could have started convulsing earlier if he'd had a different condition, but kind of like how we're talking about earlier, how the LCAD presents much later. It's more along those lines.
Good. Much later meaning much later in life, or much later in terms of duration of fast?
Sorry, much later in terms of duration of fast.
Although, to be honest, the same can also be true. Usually they'll still present earlier because, again, you rely on fatty acid oxidation more earlier because you have because your liver is not as developed. But it is possible to have people have their first presentation be older.
Alec?
Yeah.
Also, curious the time, like being 22 hours afterwards, thinking that by that time, like your glycogen storage is also like depleting at that point. So like he's going to be like really, really stuck.
Yeah. Perfect.
He probably also rule out a few things just based on his age. Like, we could rule out something like von Kierkegaard's.
Perfect. Exactly. Why?
Because it would have presented very early in life.
Yeah. I mean, like, I'm sure like each of us has had a 4-hour fast in the last like 24 hours. Like each of us has, like when you sleep, there's no way that wouldn't have presented earlier. Yeah. To get to this level, you know that it's not going to be on cookies. Again, that's fantastic. Most people do not pay attention to the timeline. So I'm really, really, really impressed that you guys are picking up on that. Good. All right. Doris, want to read the next sentence and tell us what the significance is?
Okay, so his parents report that he has a history of episodes of significant lethargy and the settings of viral illnesses, although noted that he usually improved after drinking fruit juice. Like we were talking about earlier with viral illnesses, you're probably taking in less food. I'm not necessarily sure it's improving with fruit juice. I'm guessing when he takes the fruit juice, he gets like glucose from that. So
yeah,
exactly. It has to depend on like another pathway. Is what I would think of.
Wait, what?
Like if he's taking like fruit juice, maybe he can actually go through glycolysis. So he doesn't have to like use any other means of getting glucose at that point.
Yeah. What's the treatment for diabetics when they're like symptomatically hypoglycemic? What do you give them?
Insulin?
Hypoglycemic. Symptomatically hypoglycemic.
Oh, you give them something like with sugar.
Yeah. What do you give them?
Orange juice.
Orange juice, right?
Wow.
I mean, think about that the next time you have orange juice with your breakfast, right? It's like one of the most sugar-dense things that you could give, right? It's not, don't give them like Coke, they give them orange juice. It's crazy. So same thing here, right? Yeah. People have called like, fruit juice like poison for that reason. Because it's just like pure sugar. All right. So physical exam, Lillian, physical exam.
So physical examination is notable for hepatomegaly.
Yes,
so that's indicating that there is some sort of liver damage.
Potentially. What's the next question I'm going to ask you?
Why?
Or what does this mean in context, right? You should always ask yourself, what does this mean? But the biggest mistake that students make is they don't think, okay, well, what does this mean relative to what we were just talking about?
Okay, so if we know that there's liver damage, then in the case, the previous sentences have indicated that he's having, like when he's depleted his other energy stores, he's having trouble or he's not able to use his like last ditch energy source, which is I guess like fatty acids. The liver damage would indicate also that it's something to do with like metabolism and the fact that he's having trouble after a long fast.
Yeah, to be honest, hepatomegaly again is a really non-specific thing. I think it's good to point out that so I would say for this sentence, it implies that it is something that is metabolic. Outside of that, I have a harder time coming up with a good mechanism for why you would get hepatomegaly in this condition. But other than to say like in general, deficits in metabolism will often lead to hepatomegaly. Perfect. How about Anna? Can you explain the labs?
Okay, labs drawn prior to IV hydration with glucose-containing fluids are significant for hyperglycemia and low ketone bodies with an increase in C6 to C10 acylcarnitine species. Just from seeing it over and over, if I see an increase in C6 to C10, it's going to make me think, oh, MCAD. But labs drawn prior to IV hydration. Hyperglycemia and low ketone bodies, so that means he has a hard time producing glucose in ketone bodies, so those pathways are deficient. And
why?
So that would narrow it down.
But why?
Well, if he's hypoglycemia, then you can't produce glucose or ketone bodies.
I don't know that I would have reached the same conclusion. Because again, you have to think, so you said, oh, I think this is MCAD. So then the question you should ask is, okay, how could MCAD lead to hypoglycemia? Not hypoglycemia, oh, there must be a problem with glucose production.
Right. Well, I went backwards. Yeah, I didn't really connect the two. I don't really know how they...
Who can help? Who could explain why?
With MCAT, don't you have a hard time degrading the fatty acids so you can make acetone? And you need that acetyl-CoA to be able to go into like both your TCA and make your ketone bodies also. So if you don't have that, then you can't make either of them.
Perfect. But why are you hypoglycemic?
Because you can't go into your TCA cycle or go into your ketone, like the ketone body cycle either. So like, I mean, synthesis.
But again, you don't get glucose from your TCA cycle.
But your acetyl-CoA is still decreased in that case.
So that maybe the
You can do
sorry.
You're close, but I still not. It's still not clear from what you're saying to me. Who can explain why you'd be hypoglycemic?
Because you use up all your glucose trying to get energy.
Yeah, exactly. Right. So if I can't use fat in order to get energy, then I am going to be over reliant on glucose. Does that make sense? I mean, you were kind of saying that, but you want to make it very clear. Okay, good. So who wants to give the standalone question here? Each one, want to give it a shot?
Okay, we've already established that this probably due to MCAT. So I'll just go ahead and say which enzyme is deficient in MCAT.
Yeah, perfect. Exactly. We think we know what the answer is. Why is it not glycogen phosphorylase deficiency?
You have like myoglobin.
But I mean, just the lack of the fact that they didn't say something about myoglobin doesn't necessarily mean that it's not true.
Is that because McArdle's disease, which is a muscle glycogen phosphorylase problem?
Perfect.
So there's no liver problems.
Yeah.
And they wouldn't have hypoglycemia.
Right. Yeah. Exactly.
And they wouldn't have a buildup of the azocarnitine species.
Perfect. Exactly. That is the most specific sign. That and one other thing. Ketone bodies, right? You shouldn't have a problem with ketone bodies even if there was a problem with glycogen phosphorylase in the liver, let's say. I mean, there's at least not a disease the OPS does on for step 1 where that's true. But even if that were true, and you had you would be hypoglycemic, you'd have hepatomegaly, even if they didn't tell you about the acylcarnitine stuff, your ketone bodies would not be low. So why would your ketone bodies not be low?
Is it because the ketone bodies are made from acetyl-CoA, so if you can still break down the fatty acids, you don't get the ketone bodies?
Yeah, exactly. Yeah. I mean, I guess maybe you could argue, okay, you had liver damage, so you would be able to, but yeah. I think to get such bad liver damage that you couldn't make ketone bodies, you would have other problems too.
Now you know the key concepts that make pediatrics finally make sense. Next, you need the right practice system to turn that understanding into real points. In my UWorld Complete Guide, I'll show you the exact phase-by-phase approach top scorers use to go from knowing peds concepts to crushing their shelf and step 2 with a 260 plus performance.